So good morning and welcome. We're Health Innovation Yorkshire and Humber. We're one of the 15 health innovation networks across England, and we cover the Yorkshire and Humber region. We have organised and are running a series of events, really thinking through how digital and AI deliver on the commitments set out in the 10-year plan. Some of you might have joined us for our previous sessions, which have looked at ambient voice technology. We've held 3 sessions on that, and a more recent session looking at neighbourhood health and what we need in place digitally to be able to deliver on that agenda. Today, as you can see from the title, we really wanted to have a think and a look at the single patient record and NHS App, and look at those commitments set out in the 10-year plan to offer a health service that really enables patients to be at the centre of their care, to have access to information about them, to be able to support them, to really be the drivers and empowered to kind of manage their healthcare. And with the single patient record as something to enable that, and the NHS app as a tool to be able to surface that information to individuals and to act as a kind of a digital assistant. So huge promises, huge opportunities, and today is a chance really to explore that in more detail and to think what that might mean for both patients and also for care givers across the NHS. Now, we'd be really amiss not to start with a patient perspective on this. And to that end, we've got Swati joining us later from Kidney Research UK, who talks at it both from a patient and a donor's perspective, but also from some of the challenges and opportunities that being able to put information into the hands of patients offers. So if we flip onto the next slide, we'll just talk through what we will be covering today. We're hugely lucky to be joined by, is it right? So just go on to the next slide if possible. Hugely lucky to be joined by Ayub Bhayat, who will start off and give us the national perspective on the single patient record and where we are. We've then got Rickles joining, who will talk about some of the work he's led in terms of delivering a proof of concept for the single patient record. We're then going to turn to the NHS app. We've got Martin O'Neill, Deputy Director, NHS England, again to provide that future perspective on the NHS app and where it's going. And then we're super lucky to have Professor Aaron Anzu Chatterjee, who will talk about some of the research he's led about the opportunities for enabling booking and use of a digital system to book into appointments and so on, and some really interesting findings from a perspective of how to reduce inequalities. Sorry, not on showing on the agenda here, but then we'll hear from Swati from Kidney Research UK. And then we'll take a short break. And then, as we've done with many of these events, we have an afternoon session really to hear from some of the innovations and some of the suppliers on the marketplace to understand how their innovations fits with this agenda. So we've got Big Picture Medical with a case study from SNE, one of the ICBs down in the east of England. We've then got Patients Know Best, who'll be familiar to many of you. And then we'll hear from Essential Parent. And the reason we've asked Rebecca from Essential Parent is we understand that the single patient record, some of the priority areas will be on maternity. So Rebecca will really bring to life some of the opportunities for that cohort population. Before we turn to Ayub, we're going to try and work with some of the tech, and we've got a Mentimeter. So please have your phones ready to answer a single question. While that's coming up, I'll just say a few words. We've run a few of these sessions today. We really like to start with that kind of national context and to learn from people, from colleagues across the system around kind of best practice, and then that afternoon session to look at some of the suppliers in the marketplace. We're really keen to hear from your perspective and your thoughts, so please do post questions or thoughts in the chat. We will be writing up this series of sessions, so anything that says might be quoted, but it won't be attributed to any individual. So please feel free to share your thoughts in that knowledge. Right, we're going to try and kick off with a bit of an icebreaker to get people engaging with this. So please, if you can, pull out your phones or go to menti.com, type in that number and tell us what would success look like for a single patient record. We'll give people a moment to do that. Hopefully people can access it. This is a bit of a test for us, so please do bear with us. Hopefully we can see some responses appearing soon. But just a huge welcome to everyone who's joined today, and thank you for giving up your time. I know it's a busy time, particularly in the run up to Easter. So few responses coming through around security, ease of access, easy to use. I think all of us who've ever worked on any digital project know ease of use is absolutely paramount. The complete record, accessible, empowerment. Great to explore that in further detail. Improved experience, convenience. Let's give a further moment for those words to come up, but we can see some really dominant themes coming up, shown by the kind of the size and I think the darkness of the words. So accessible, easy access, easy to use, accurate, secure, not having to reshare, tell once. So some of those common themes that we hear time and again from patients around the frustration of having to repeat information. Affordable, obviously really key. Continuity, timely delivery. We'll keep this open so you'll be able to keep responding, so we might revisit it at the end. But what we will do now is welcome Ayub, who joins us from NHS England. So welcome, Ayub. Maria's going to share your slides, so please just say next slide when you're ready, but I'll hand to you, Ayub, if that's okay.
Brilliant, thank you, Laura, and it's great to be here with you all. I'm, as Laura said, I'm Ayub. I'm the Director for Data Analytics at NHS England. And I look after the single patient record, or I'm responsible for the delivery of the single patient record even. And it's great to be able to come speak to the Innovation Network here, and hopefully try and have a conversation. So I'll try and not do death by PowerPoint, famous last words. The single patient record, as many of you will be aware, is one of the central initiatives announced in the 10-year health plan that was published last summer. It is central to the government's policy position, and like many of you have said in the Menti just before now, we need it to be accessible, we need it to be secure, we need to be helping to drive the transformation of the NHS, and that time is now. Thank you very much for moving the slide along. I forgot to say move the slide, please. So thank you for moving the slide along. So from a context perspective, a wider context perspective, it is a key enabler for the delivery of big reform strategies, which include the 10-year health plan, which include the shift to neighbourhood care, so from hospital to community. How do we provide tooling and data that supports the move away from sickness to prevention, which also means how do you help patients navigate the NHS better, and how do you give them healthcare at your fingertips, which is the strapline for the programme, as you will have seen in the very first slide as well. It also needs to make sure that we're giving professionals the access to the same connected record, and that's going to be central to how we're changing pathways. And I'll come on a bit more in terms of the pathways. It's very easily from a technology standpoint to look at the single patient record as a technology solution. It's much broader than that, much bigger than that. It is about transformation of services that we provide using digital data as an enabler to transform those services. How do we make sure that it supports faster research and new treatments? That we've been talking about this for quite a long time. And how do we make sure that with the fantastic initiative around the Health Data Research Service, how does single patient record enable the Health Data Research Service for the future? Okay. And analog digital is a given. That's the whole premise of implementing a single patient record, and a lot of the technology investments coming up in this spending review now that we're in 2026, or the 1st of April of 2026, and you'll be pleased to know none of this is April Fool's, by the way. This is genuinely something that we're going to make happen. We're going to do this, and we are going to help support the transformation of the NHS. Sorry, so there was some background and feedback there, with some music as well, which was quite nice. So if I can have the next slide, please. Thank you. So from an impact perspective, right across the ecosystem, what are we trying to do and why are we doing it? We want to make sure that patients have the ability to understand their information through the NHS app using the single patient record as the underpinning capability that gives them that visibility of what services they are consuming, what conditions they're managing, but supports faster triage. We want to make sure that we're giving clinicians a single version of the truth. We've been talking about single versions of truths for such a long time now. And how does a single patient record give that information to clinicians? So, there are far too many scenarios because of disparate data, unconnected data, disconnected data. That means there are silos, and clinicians have an incomplete picture of a person's record. And we need to make sure that that information is available to them so that health and care professionals can have the same details, or the most pertinent details rather, that they need to treat a patient. We need to make sure that we are securely providing the availability of data that underpins the single patient record. As I was talking on the first context position, with initiatives like the Health Data Research Service, how do we make sure that approved third parties can have access data securely for research? How do we make sure that we're using the data underpinning this to actually drive and use artificial intelligence to change models of care and drive care in a different way? So we've got a significant transformation agenda, and that is not just about research, but it's about how do you make sure that you equip the clinician, how do you make sure you equip the patient, and how do you make sure that the technology points to supporting the transformation of care delivery. And I think that's going to be paramount in the delivery of successful delivery of the single patient record. Can I have the next slide, please? So these are some of the key principles. I won't labor every single principle, and I'm sure people can consume them. But the single patient record is going to be underpinned by a number of different principles, which we need to make sure that we stick to. And all of the principles that you see on the screen right now to make sure that securing patient data and confidence, I think the confidence being the key word, it comes back to trust. If we don't have the trust of the public and the clinicians, the program will not succeed in the transformation agenda that it's trying to push forward. So we need to make sure that, and I was at Rewired last week, I'm sure some of you were there as well, but at Rewired, I had a fantastic discussion on a panel chaired by Chris Fleming, and Charlotte Refson was also there as well. And we had a really good discussion in terms of consumerism. So how do you make sure that you meet the patients where they are? And that comes back to strong engagement, strong user-centered design. So we've got to make sure that when we're developing the single patient record, we don't forget who we're developing it for and what we want them to get out of it. This is about activation as much as it is about transformation. So we have we can talk about the workforce, but a lot of it is also about actually how do you engineer and how do you change patient and public attitudes to using technology to drive self-care, and how does a single patient record support that change and transformation to activate those patients so that they are ready to use the technology that we provide. We've talked about it quite a lot in the past in terms of, and we've heard it over the last 12 months, 18 months around patients having to use AI, large language models provided by ChatGPT, Gemini, etc., to interpret some of their clinical information. We've got to make sure that we're meeting them with these capabilities, that they're not going to anywhere else, that they're not putting their sensitive patient data in other platforms, to understand what it really means. So how do we provide the capabilities in a manner that actually that they would utilize and use, but then also able to understand what their next steps are. So these are the key principles of single patient record. Again, like I said, I'll happily take questions in a few moments on all of this, but just setting out the principles at this stage. If I can have the next slide, please. So I sent it on the previous slide also. without strong engagement from both patients, citizens, and as well as clinicians, we will design for the few, not the many. And in my experience, the best way to design a service, a system, is to work with users. And I don't mean spend lots of times doing discoveries and lots of 100-page slide decks that nobody will ever read. I'm talking about actually fail fast. So actually develop something and test it with one, scale to a few, and then on the back of that, how do you take that to the many? So the single patient record is taking that approach where we're involving patients at the heart of the design. So we've got a very engaged patient group, but then also how we're involving clinicians to make sure that it matters to clinicians most. So some of our early use cases or transformation areas is around maternity. One of them is around maternity, and we're working with a couple of trusts in the Northwest, with midwives, and also the chief midwifery officer, to make sure that we are developing the maternity solution or the maternity use case capability within the single patient record ground up. So it's not I think whatever we design in the center is always going to be wrong. Quite frankly, I don't think it's the right way to do it. And I think that all of these things need to happen on the ground and then be scaled. So, what's the famous analogy? Start small, scale fast. I think that's the mantra that we will adopt in developing the single patient record. Underpinning all of that, obviously engaging patients and gaining their trust, and engaging clinicians and gaining their trust is going to be central. But then making sure that they've got the confidence in the technology as well, that it's secure, that it's usable, that the integration points are correct, that the integration points are robust and supportable. There's going to be hundreds, if not thousands, of integration points that we're going to have to manage. How do we reliably do that? And those are the activities that I hope will be taken up in the very near future as well. If we could have the next slide, please. Thank you. So you've heard me talk about STAs. It sounds that STAs always goes through my mind as single tender actions, which my CFO will always say it's a no-no, and it's something that we should avoid. But STAs in this context is around service transformation areas. So these are the ones where we absolutely co-design and shape the SPR use cases to make sure that they are grounded in the real world needs. There are groupings, and currently we've got about between 10 and 15 of these service transformation areas, and they support fundamentally the reform priorities. So how do you move from hospital to community? How do you support neighbourhoods? How do you support frailty conditions? How do you support maternity challenges that we've got? How do you make sure that the SPR and the transformation areas are supporting the meeting of the 18-week minimum, 18-week target for waiting lists? How does the SPR support the delivery of cancer care and shared care plans, which I know there's fantastic work going on in the shared care records currently, working with our teams at the moment. But how do we make sure that we take that learning and we develop it into the single patient record? How will they work? We'll make sure we map out the current processes. We'll make sure we work with organizations, understand user journeys. So we're designing these solutions which make sure that they compare the current versus future models of care, and we're reimagining how we deliver this care rather than just actually digitizing an existing process which is probably not optimized, and really taking it forward to be a digital first model. And that's the ambition of the service transformation areas. Adoption is always a challenge in the NHS. How do you get adoption? And again, this is not a centre's role. The centre isn't the advocate for this. It's a poor advocate in very many ways. And what we need to do is champion local organisations, local clinicians, local staff to move the SPR into an adoption phase where the buy-in comes from the ground rather than the centre pushing an agenda. Can I have the next slide, please? So on 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 how we do this and making sure that we are improving care directly, we need to make sure that patients have one view of their record, and we talked about it being available in the NHS App, and you've not heard me major on artificial intelligence. Those are things that we're going to have to make sure that we use to make sure that we're giving patients the capabilities that they need to drive the change that we're trying to get to. So again, from that perspective, how do you layer AI within the single patient record to be available both within the app, but also the viewer that clinicians will use as well? How do you make sure that the patient retain control over how their data is used for both direct care and research? And those are commitments that we've made in the 10-year health plan as well. So we've got to make sure we stay true to some of those principles that have already been confirmed. We need to make sure that we're giving clinicians the right view and access to better, more consistent, more comprehensive and relevant patient information that ultimately enables safer and faster care. So again, reducing the multiple systems that clinicians have to interact with, and also the repeated requests of, oh, what did you say in that previous consultation with that other clinician? I think, how do we get to that? We need to make sure that operational teams also get more streamlined, effective information by cutting out the sort of unnecessary tests or the missed appointments. How do you stop those things happening? And how do you make sure that burdensome admin time that's taken up for clinicians as well as operational staff is reduced? We need to make sure that social care teams, and I think somebody mentioned, I saw a comment pop up around care. I think social care teams also get the access that they need for the patient record, to make sure that professionals in the social care environment are seeing the same information that healthcare colleagues would see from the single patient record. And then finally, the researchers and the innovators, how do we make sure that they've got the secure access to the valuable data? You know, we talk about the value of data, we talk about the valuable data that the NHS holds, but how do we make sure that that data is available for medical research and helping to shape new treatments for the future, and that's supporting patients and also population insights as well, so that we can deliver care services, health and care services for the whole population of England. Laura, I'll pause there. I appreciate I have rattled through that on purpose. I wanted to have more of a dialogue. So hopefully there's a few questions in the chat that I can try and pick up, if that's okay. I think somebody is trying to stream the questions as well, but I can only see a few questions that have come in. Or not a question, there are more comments. Is there a view to include all age continuing care services as well? That's from Jane. It would be great, Jane, if you could clarify what you mean by that, first of all, before I answer that question. Happy for you to come on and speak, if that's okay.
Hi, yeah, it's the one of the first slides. It was you were talking about including within the single patient records, like the community services and the GPs and the acute services. It's whether the all age continuing care, because we access quite a lot of that information, whether is that something that might be included within the single patient record or not?
Absolutely. I think this is about the full comprehensive position, which includes records that sit in continuing healthcare teams as well. So from that perspective, Jane, we will absolutely be trying to integrate with those toolings as well. And I think there's been a helpful standardization in continuing healthcare IT systems in the last few years as well. And fewer integration points make it easier to manage. So I think yes is the answer to that, and making sure that this gives the single patient record is meant to provide a comprehensive position, and therefore should include every system that holds information about a patient.
Okay, thank you.
I think the question from Barry, will the record start from day one when a patient enrolls, or will it include historical data? It will absolutely include historical data. It will need to make sure that we are providing, I think otherwise you're providing just from the day that you've enrolled, and that's not a comprehensive record at that point because you're missing all the history. So it will need to provide the historical information as well. I think where do you stop with history is a big question, but those are things we're going to have to work through. Will NHS suppliers and partners shaping the models and architecture be designing for more open ecosystem or control platform? This is something that we're working through right now, the architecture and how the architecture will operate. But we will need to operate a much more open architecture, an open ecosystem, to make sure that we are providing the capabilities that allows for other integrations to happen as well. How do we design? I think I'm sure Lee will cover some of the POC information or proof of concept stuff that he's been doing shortly as well. But we will absolutely be designing a much more open ecosystem to allow for further interactions and making sure that we are able to work with different areas as well. Laura, your question, I think that's something that we've heard a few times in terms of patients want to contribute to their health and care record, and we've got to make sure that we create the capabilities for that to happen. So within the single patient record, we will be holding information generated by the patient themselves or the citizen themselves to work in that, to be available to clinicians. If we're going to get to proactive care, much more sickness to prevention, we've got to find early ways to intervene, and that invaluable patient data is going to be crucial. And there's stocks of it on our phones already, right? Our phone tracks how many steps you've done, what's your resting heartbeat, what all of those sorts of things. But how do we make sure that we make that available? And there's loads of work that's going on already. Some good work that if Martin O'Neill is here right now, I'm pretty sure he'll cover some of that later as well. There's some good work that the teams have been doing already in that space. The next question, not a question, but agree there's lots of potential for links with maternity services, many of the national services, and are using the same provider. Yeah, agree with that, totally agree with that. And then Nicholas from North East London, you mentioned the great work achieved with shared care record and shared care plans. Today, how are the national team using the work on the basis for a single patient record? So we have been working with the existing shared care record teams as well. So I think Lee comes on next after me. I'm sure he'll tell you that we've been engaging with him and team as well. And we've been doing some proof of concept with the shared care records. The shared care plans and cancer is an area that I'll focus on. So Saf Angelo from one of our teams is working on making sure that the shared care plans being developed, because we need to do that now. That's a commitment for the cancer strategy and the cancer plan, and we need to make sure that that's available. Now we're trying to join up the ways of working rather than actually recreate them. So when we're designing the shared care plans for cancer, we'll be taking the learning by working with the shared care record providers and systems to make sure that it is the same model that we ultimately implement in the single patient record as well. And then Becky Case, plus the bonus of a large digital aware demographic. Yeah, indeed. I think we have got a much more and it gets stronger every day, right, in terms of the number of people who are digitally aware than those who aren't. We do have to make sure that it's an inclusive design, and make sure that we account for those who won't interact through digital mechanisms, and how do we manage that as well. And then the final point from Jane: how can we engage to help develop the system or commission it or access it? There is lots of roundtables being held. There is lots of different supplier sessions that we've had as well. We've got quite a strong engagement mechanism, Jane. I will drop an email address as well in here as well at the end, where you can write to it with sharing your thoughts. This has to be a movement. It can't be a diktat. And I think the opportunity to come talk to you all is fantastic, because this is how we develop the movement. And I think we've got to create the movement. So need your help. and I think you're pushing at an open door, Jane. Is what I would say. There's a few more questions that have come in. I thought that was the last one. How would you see access being managed for local authorities, VCS, and other organisations who increasingly work in tandem with NHS services and require information? We've got to make it available where there's a need. If there is a legal position where the need is accepted and validated, we've got to make sure that we're providing that access to local organisations, be it local authorities, the voluntary sector. We know that health and care services are delivered by many professionals rather than just hospitals and GPs. And therefore we need to make sure that the record, that's why the social care elements are really important. We're going to have to provide access to our systems and services through those toolkits as well. Lee, I'll skip your comment, but I totally agree. And then Dr. Addy, how up to date will the records be, and how soon can patients access records after they have just been typed in, e.g. in patients reading ward round notes? TBD at the moment. It's a big question. I'd love to say instantly, but we know that that's not how records are typed in either. We know that it takes some time. I'm hoping with ambient voice things will change, and how quickly record information into systems will get in will be faster. And the expectation is, it's a bit like when you make a transaction in your bank account, you see the money leave your account straight away, right? Patients are going to want the same sort of service, and we know that's the sort of expectation that's going to be set. You know, if you look at Amazon and you're ordering something from Amazon, once you've ordered it, you can see every stage of when it's been picked, when it's been dispatched, when it's out with the courier, and when it's been delivered. That's the type of environment that we need to create. And there's a whole debate on consumerism at Rewired last week as well. And consumerism is, you know, either you take it to the patients and the public, or they will find an alternative. And I think we are at that point where we need to take these services to the patients much, much faster than we've ever done. Otherwise, they'll start to look for alternatives. So I think it's in our gift to make this happen and change this. And I take this as an opportunity and a challenge, but surrounded by wonderful people across the NHS who have so much experience. How do we create the movement? And I guess I'm asking you all to join the movement with us, and help us deliver the single patient record for the many. Okay, Laura, I will pause there and stop there.
Well, thank you so much. Really helpful, and really interesting to hear that positioned as, you know, as a movement, particularly when we think about expectations of the public in terms of how they manage their lives and being not just digitally confident, but kind of, I guess, digitally expectant about the services that they provide. Thank you very much. Sally's commented, super impressed with your question, answer, agility, clarity, responses. So yeah, a huge thank you from the audience. And we will, assuming it's okay, Ayub, share the slides out with everyone today.
Absolutely.
Amazing.
Thank you all. Have a lovely day.
Fantastic. Thank you.
Cheers. Bye-bye.
So our next speaker brings what we've heard from Ayub to life in terms of how this is being deployed in the real world. So I'm going to turn to Lee now. Lee, are you happy to share your slides? We've got them ready, but
yeah,
would you like to?
Yeah. I can put the slides up. Yeah, it's not a problem. Just give me a mo, Laura. So just while I'm doing the technical bit, I'm Lee Rickles. I'm the director for Interweave. I'm a CAO at Humber Teaching NHS Foundation Trust, and a few other bits, including the Regional Adjustment Digital Flag SRO. Well, this week anyway. So while I kill time and get the presentation up. Yeah, so we should have the presentation in front of everybody. So mine's about a 20-minute slot. I'm going to be whizzing through some of the stuff. People who already know the shared care record community and Interweave, I will be wasting a few of your minutes' time, but again, there's a wider audience, so it's just give a bit of context. We're being part of the proof of concept work. Very technical piece of work, but again, the context is very similar to where Ayub has suggested that this is around joining information about people that people then act upon to provide health and social care, whether that's VCSE, Fed sector, consultant, paediatrician, or a CPN. The difference with shared care record community and a single patient record, it is quite fragmented. I will touch on that in a little bit because the shared care records are across ICS or multiple ICS footprints. So there is an issue of joining bits together. And I will be touching on the context of the proof of concept piece. So what's the problem and why do we have shared care records? So many moons ago, there was a LICRA program. I think John Farrington's actually on the call. He was quite an instigator of this piece. And it was really, there's a number of consequences, real world consequences for the lack of sharing information. I mean, some of the big ones are Baby P, Victoria Columbia. You've even got the Harold Shipman, that lack of oversight and information, you know, if has caused serious harm. But there's also the massive opportunity for benefits as well. If we can get the right information to care workers at the right time, it makes them far more effective. It gives them more time to care, and it removes that delays duplication and, you know, and stops them tragic outcomes. Now, the single patient record is focused around the patient. The aim is to have the professional around it. It is join information together. It's an aspiration that's been in health sector for at least 20 years, if not longer. It's one that's always been quite a challenge and quite difficult, the way we're configured in provision of care in England. And I'm saying England because single patient record is England. Wales, Scotland and Northern Ireland have their own approaches. So we're just going to be cognizant of that fact. And there's some other work that's going around on joining the UK record together. But the key bit is the value, the aims and the principles are valid. The hard bit will be, getting something that actually works. So from an Interweave point of view, why we're involved, and there are many shared care records, there's some really exceptional work some of them are doing. Main reason we got involved in the proof of concept was really we're vendor neutral, we're very standards based, and we are aligned to them national standards. So there are, and I will touch on it, there's 3 proof of concept pieces that was taking place. We was part of 2 of them, and the main reason was it's an NHS owned asset. We do work to a standards based model. It does mean that when you are joining data together, you've got a better chance. I do apologise if there's any background sound. I'm currently in a car showroom because my car's in for an MOT, so I'm just trying to work around some of the logistics. But hopefully it doesn't come across too badly. Key bit is trying to get uniform data and presentation. If the presentation is crap, nobody's going to use it. If it doesn't match the experience, and when we say an experience, it's a different experience to somebody like me who's starting to get a bit old. Eyesight's not as good as it used to be than it is for a young person who is very digitally connected. So again, when we're talking experience and interaction, especially when you're starting to look at the how people will actually engage and use the technologies, it could be very, very different, including we don't even need an app. You know, we have this thing called Alexa or whatever that seems to do okay, and other methods. Free proof of concept. We've done quite a lot on standards, especially around social care. We've led the way on social care standards with FHIYH, fast healthcare interoperability. Listen to it and forget it. It's the same as knowing what your standards are for your petrol and your diesel. Most people don't know, but it's just there and it works. So Interweave itself, we link into a lot of the national systems. So the patient demographic service, we have a master index, we have an ability to join disparate bits of data together. Now, the hard bit I would say on Interweave and doing what we've done is really getting the data from EPRs, social care systems, BCSE systems, or even giving access to them as well in a consistent way. Every system has a set of allergies, and I'll tell you what, they don't match. So it depends how it's being transcribed, how it's being used, all that type of stuff. So the challenge around joining data together is a big challenge, and that's part of the issue we have on single patient record. It's part of the issue of all the shared care record community, and it is if you want to provide a longitudinal record that's actually of some use. If we don't, we'll just have a disparate set of data, And as much as you think large language models and AI are going to crack that one this year or next year, that's inconclusive and probably unsubstantiated. Maybe 5 to 10 years time, maybe with quantum computing coming in that can have that power to deal with some of that, but we're still in a world where it's very inconsistent. We have a number of apps within Diagnostic. So, you know, there's a care portal, patient engagement, we're linking to care planning solutions, booking referral, discharge solutions. Some of them are within the Interweave stack. Some of our solutions that are built by the actual partners, like the discharge solution, that's one that Knots had developed, for instance, who's one of the partners, as you can see on the right hand side of the slides of who we work with. The bars is with some of the partners. Not everybody uses the care portal, some of it's in the EPR. And I will get to the point of real world impact. I think I did leave this one in. It does actually get used. People do see value. Is it perfect? Of course it isn't. It's a work in progress. All these things are. Are we joining data together? Yeah. Is the technology able to read right back to systems? Is it able to link into other solutions? Absolutely. Does it? No. And this is where it comes down to the speed of take up, the resources, and the complexity of doing that and joining data together. To some degree, the tech in the middle is really, really easy. Getting the move around so VCSE is a really good example. VCSE organisations are not set up the same way as the NHS or social care, so they don't do things like DSTP toolkits as much. They speak a slightly different language. They're quite small sector, so you've got to really change. We've really got to change how we operate to be able to work with them in a constructive manner to ensure we are providing care and the right information. What we can't do is try and do an NHS solution on some of these small sector organisations. So what was the proof of concept? So getting to the point. We did one called Virtual. We didn't come up with these terms, by the way. This was the single patient record team. And just to build on what Ayub said, the single patient record team have really worked with the wider shared care record community, really have had lots of workshops, lots of engagement. They picked up a lot of lessons learned. They've had some very focused workshops on lessons learned from the National Programme for IT. Although I would say the National Programme for IT's ambitions were very different to the single patient record. The single patient record is not removing EPRs. It's building on EPRs, where the National Programme for IT was literally take everything out and build it all back in again. It really is trying to create a set of glue, at least the same type of glue that joins things together. So how do we take what we've got into Interweave, where we've got a federated approach? We don't persist data, but we're able to link data together. So basically use a modern tech stack with APIs in the cloud and provide the access. So from the piece we did is the feedback generally and how it performed was it removes that dependencies on third party IP, which it does because you've got technology. Because it's federated, the data ownership model of data processor and data controller becomes easier. I would say actually that is probably more of a mindset and how you use the data. There is an ambition for NHS England to do stuff with the data you hold. That becomes a data processor. That becomes a different legislation, which might require another act or legislation change for that to be effective, especially when we come to GP data, because there's a very interesting data ownership model there. This type of layer doesn't really work in practice. So most of the existing NHS England tech, either things like the Federated Data Platform or the Summary Care Record or the National Care, are all built as very big persistent layers. So this really was seen as something that would require a bit more. And also how you tie into the AI type of stuff. And there's a real valid point there, because to train on AI and to get the speed of response on AI, we've seen that as well on our proof of concept work we've done on Interweave or with Google on AI, that you need a level of persistence for it to be effective and timely. It's no good your AI is brilliant, but you've got to wait 2 minutes for the information to appear. Everybody's given up the ghost. It needs to be seconds. And our current federated approach is it needs to land within 2.5 to 3 seconds-ish. I just wish GP Connect could achieve them timescales, which it can't at the moment, unfortunately. And there's just a general question on what we did around performance and availability, which I think we've got a unique option on Interweave. So, but what I'll touch on now a little bit is just a little bit more on the free proof of concepts. Because I think personally, and the feedback I've had with other people is the free proof concepts are looked at is one, which was option one, which is really looking at the current shared care record community. And the positive bit there, there's a lot of time and effort that's gone in there. And they do see that as the starting point now. So that's really positive from the initial work. And we're part of that original option one, that initial proof of concept. What I would say is the method of using something like National Record Locator Service, which is literally, here's a pointer and I'm pointing to something else, is crap. It's useless. It's totally ineffective. If you've got a paramedic that's going to have to fire up the National Record Locator Service and look through 42 PDF documents to try and find information, it's just not going to happen. It won't get used. There's a whole thing. And the ConCare, so the Connected Care team, NHS England rebranded the Shared Care Record to Connected Care because they finished the Shared Care Record programme and then rebranded it Connected Care because that's the way we do things in the centre. Nobody's actually done any usability pieces on the Connected Care programme and using NRL at all to date. It is one I've pushed quite heavily. We're missing the point completely if we're not considering usability and experience. Usability and experience are everything. If we get them right, the consumer conversation we touched on before will be an amazing experience. It will work for the consumers. It will work for the practitioners. If we just give people, here's a load of PDF documents, yeah, it's probably going to meet Mac unless they want a load of PDF documents. The other one was a central integrate, so a very big persistent model. I'd say this is generally emphasised more on the analytical people, missing the frontline requirements. But hey, we've got loads of data. We can do all sorts of weird and wacky things with it. Absolutely required, but there are pros and cons to how that happens as well. And potentially there could be some political issues depending on what type of solution is used there. And I won't suggest any particular suppliers, but there is definitely one that's in the media that could be an option, which would be a bit scary for the general population. And then option 8, the proof of concept virtual layer, that's us. Realistically, NHS England looked at them 3 options. Realistically, it's all 3 options. It's using the existing shared care record community, expanding, consolidate and pulling that together, working with the vendors that are there and the EPR vendors and others that and the shared care records, social care records. There is a need for a persistent layer. The question is, how do we achieve that and how do we tie that into the SDEs? Because in some ways, the central integration solution does develop a model for feeding the secure data environment. And you need some way of messaging. You know, your email system isn't one big system of messages. It fires from one place to the other. So really, it needs all 3, if not more. The key bit is how that's built up. And that's still very much a question mark at the moment. So that's whizzing through my bit. I have 20 minutes. I think I'm doing okay for time. So we've probably got time for a few questions. Can I take the slide down, Laura, and then I can just read what's in the chat, or you can pick up any questions. I will stress this has been a team effort. It's not me. It has been the wider team, and there's the wider Interweave partnership as well. So what I would say on Interweave is different areas do prioritize different pieces of work and different items. So there's already a high level of difference in the Interweave, 15% of the population of England, let alone the rest of the community. So back to you, Laura.
Fantastic. Well, thank you so much for just bringing that to life in such a kind of easy to understand way. I really appreciate it. Really helpful to understand the different architecture options for how we deliver that and then the different implications of that. But you brought to life some really key kind of fundamental pieces around that accessibility and usability, both from a clinical but also from a patient perspective. You talked about the need for standards, but then how do you balance that, as you identified, with very small organisations who, you know, aren't logistically necessarily going to be able to kind of cope with kind of massive, typically NHS demand. So it'd be lovely to hear a bit more about how we might manage that. And then, Duncan, you might want to come off mute and say a few words, but Duncan's highlighted he's from a third sector organisation. Would love to be kind of part of the thinking. Duncan, did you want to say anything more?
Yeah, thank you. It's just, it's great to kind of have the third sector kind of thought about in these things, and I've been sort of championing it a little bit from a distance. So, you know, we're one of the larger mental health organisations based out of Leeds, working across West Yorkshire, And we do data protection toolkits. We work within sort of NHS standards, etc. But a lot of our partners don't. And so that bit about how as we as a bigger organisation can we help and be a conduit to thinking about how those smaller organisations come on, and we'd be really interested in just having that conversation at some point.
Yeah, really excellent point, Duncan. And the IG and data people have really understand there's a different language and different way of working. Other organisations don't necessarily have to have a DSTP toolkit, and generally they are complying to GDPR and common law confidentiality, etc. So it's implicit on us as larger organisations say, actually, we are reasonably confident. We've got enough confidence to say they are doing the right thing. Or if they aren't, how do we support them? But we do need to change the language a little bit, because something like the DSTP toolkit or the CAF, which is now coming, which is definitely embedded far more in the current version, can seem very alien. And again, in some of the smaller bodies we're dealing with, the people that are doing the data protection are the same people that do the IT support and the same people that do other things. So, Duncan, we'll dovetail you in from an Interweave point of view. Are you looking at which organisation are you, Duncan?
So North Point. So we're a mental health charity.
Okay.
Yeah, North Point.
Yeah.
The other point, which is worth just mentioning, is when we're thinking about kind of the rollout and the kind of cost of transformation, there is a cost to these organisations as well, and often that kind of gets overlooked. And we don't want it to be a stumbling block. Somebody's put in there that the usability needs to be kind of easy, otherwise it won't get taken up. But if we can't take people with us, organisations with us, that will be the same situation. So I just think that kind of rollout is really important to understand across not just the NHS organisations.
No, absolutely, Duncan. So again, this is, I'm talking Interweave rather than single patient record, but the principle should be the same. That's why it's internet based. That's why it's cloud based. So we don't end up having to invest in expensive HSCN connections. It reduces really any cost for actually using the systems. There is the issue of what information and what systems you do use. The Department of Health and Social Care are suggesting to me at the moment on the social care side, 50% of providers do have systems now, and we're working closely with them providers, or at least a single patient record team, of how do we get the data flows, because they're quite new systems, so they are quite they're in a good position for the APIs and sharing, albeit I'm talking a very technical capability. The key winning point of this is going to be hearts and minds, changing processing, working differently. Otherwise, the technology is a waste of time. It's like having Amazon, but nobody knows Amazon's there because everyone still likes to go to Waterstones. Although Waterstones was very well, actually. They have broken their whole marketing philosophy has worked really well for them in the last 5 to 10 years. So sorry, Duncan,
No, it's good. Thank you. No, let's chat in the future. Be great.
Yeah, absolutely. So Laura, did you want to pick?
There's a couple of other questions. So one around kind of going back to that kind of accessibility piece. So Dr. Addy asked, for those who don't have mobile phones, can they see and utilise their own records reliably from a public library computer, for example?
Yeah. Well, at the moment, so the single patient record will be. I mean, you can have a portal access. It doesn't leave a footprint on the device. It does have multi-factor authentication, so it's just down to how you achieve that multi-factor authentication. I think what I would say, Dr. Addy, is I don't think that one's solved at this point in time, because we've still got the challenge of things like proxy access. So when you're making decisions on other people, because again, especially when you get to children and young people, that's not black and white. It's not 18, all of a sudden I can make my own decisions, and under 18 I can't. That's not the case, for instance. Or when you've got carers looking after other people, how that works. So the access bit could have issues, and also there's a minor issue on reasonable adjustment and accessibility standards. So they may be able to use that piece, the laptop or the computer in the library or other locations. The question is it set up for them particular people? So there is a whole thing of, if we want to become more digitally capable, there's a whole social mindset, because it's not just health, it's not just social care, it's the whole of the country and how the industry puts together, banking, shopping, everybody wants to go this way, local government, it just needs to be joined together more. So the answer is yes, but it depends whether that'll actually work for the individual.
Thanks, Lee. And another question from Matt, which kind of talks kind of the ethical, some of the challenges here. So if you're pulling data from several sources, how do you decide the source of truth and what you present to the user? How do you handle conflicting data, or is all the data provided and the professional has to make a judgment? And is there the ability to highlight conflicts?
So in Interweave, we have the clinical advisory group with clinical safety that have made decisions on the primacy of particular data types, depending where they're coming from. So, for instance, pathology data, the pathology system is the master, not all the other copies, for instance, and that type of thing. Where there is duplications, it does flag there are duplications in the record, so then the professional can see the other information. But that's really been developed by the clinical leads and clinical safety side. So we've done our best to minimise any clinical risk and provide the most appropriate sets of information. Is it perfect? Well, it minimises the clinical risk. It's better than having to either having no information or having to filter through it, but you still have access to the other information if required. And again, that's in the context of role, of course. A paramedic is looking for a very different set, or shall we say, a far more focused set of data compared to, shall we say, a psychiatrist, for instance, who will want slightly different. So there is something there. If you want more, probably Paul Warwick and Jason Brock are probably my two key people that could provide more data on that, on Interweave. It does depend on the single patient record if they check that process, or what they do is check the on a persistent layer, if that's the way they go, or something else. They come up with a method of doing that within the persistent layer, and that's when there would need to be a data owner, because they're changing the data that's being received to something else, where we're a data processor, but agreeing how we present the data and how we have that primacy. Hopefully that helps answer that question. It is all there, it's just presenting it in the way that is as helpful as possible, but can flag other stuff is available.
Thanks, Lee. It's a real minefield, isn't it? Because how do you intelligently show the right information at the right time to help with that decision making, especially if you've got reams and reams of it?
Yeah, I mean, the challenge is even just trying to triangulate. If you've got 4 or 5 bits of data and you've got mixed transcriptions, trying to even get the data changed is a hard slog for patients. So as my wife knows, who's never smoked, but is down as a smoker in the GP practice because somebody probably transcribed something wrong. But that's what happens. It's people, it's human error. It's just how do we deal with some of them inconsistencies.
Fantastic. Any other questions for Lee? Feel free to put your hands up if you'd like to ask a question. Otherwise, we'll say a huge thank you to Lee, particularly for bearing with us in the car showroom. So thank you very
sorry
much.
for doing it. It's just the way I've had to put it in just to get the MOT out the road before I hand it back. So yeah, thank you for bearing with me. And yeah, thank you for the opportunity to speak on behalf of the Interweave Partnership. Thanks.
Thanks, Lee. And we'll circulate the slides, assuming that's okay.
Yeah, it's absolutely fine to circulate slides. And if anybody wants any more detail, we've got the Interweave website. It's also different partners have different websites. So Leicester Care Record, Leicestershire and Rutland, I should say. Laura would tell me off. Notts Care Record, Andrew Hall's actually on today. They're really onboarding rapidly. Yorkshire Humber Care Record, and we've currently got Dorset coming up. All of them have their own sites, and we have a load of stuff on Interweave. The partner sites are generally more focused on the patients and carers. Interweave is more focused on the support and some of the technologies on behalf of the partners. Okay.
Fantastic. Thank you.
Yeah. Okay. And just Dr. Addy, we do have a number of care homes that do actually have staff and have a particular access. And I have a specific issue where it hasn't been used and it has been there. It does tie back into do not resuscitate and resuscitation action, but we're picking up some of them issues. So not all care homes have it. Sorry, Laurie, you can kick me off in a minute. The issue is pace of rollout, and we do have a challenge at the moment with the headcount reduction in ICBs, the reduction in resources going to shared care record, it's being redirected to single patient records. So there is a whole thing of where do we sweat assets, because historically lots of money has gone into acutes and not necessarily joining data together, which contradicts the integrated health organisations and the moving from hospital to community. So there are some challenges. Not everything's absolutely brilliant. We could do a lot more, if we redirected resources from, shall we say, the same old to where there's big gaps or higher level of risks, when we just got to look at all the coroners reports out there, and it's generally, information sharing is definitely comes up there very, very regularly across multiple organisations. So I'll shut up at that point, Laura.
Thank you. Thanks for just highlighting that, the real world challenges of implementing this. We're going to move now to the NHS app. So really, NHS are really positioned in the heart of the 10-year plan as that kind of front door for patients, as the way to access all information moving forward, as the kind of the patient-facing element of the single patient record. So to talk to us more around the thinking at NHS England, we've got Martin O'Neill with us. I'm hoping. Martin, are you there? I think I saw you in the chat. There we go.
I
Fantastic.
am indeed, Laura.
Excellent.
Hello,
I'll
everybody.
hand to you then. Hello.
Thanks, Laura. Good morning, everybody. Let me just pop those slides up on screen. I'm going to speak for about 10-15 minutes, give you a general overview. This isn't a detailed deep dive into the app by any stretch of the imagination. There's an awful lot going on, as always. I'll talk to you first of all a little bit about my role. So I'm a Deputy Director of Digital Diagnostics and Therapeutics here at NHS England. The concept of this is to try and come up with some of the key enablers that sit behind the innovations outlined in the 10-year plan. And we've already heard quite a bit this morning about the single patient record, and that is one of the key building blocks behind that innovation. It is a cornerstone of how many of the experiences that have been talked about and thought about and designed and built in the NHS app will need to function, and they'll need to utilise that single source of truth and that data to an even greater extent than they currently do. And that's true for some of the innovations I'm going to be talking to you about as well, alongside that, with regards to things like digital therapeutics, things like at-home testing or self-sampling, the use of biosensors, wearables, and really the evolution and the kind of continuing growth of the personal health record, which really is about a broader set of indicators, information that need to be available at a timely point in a pathway for people to make better decisions or to have better context about those decisions that they're making. And when I say people, I mean the patient just as much as the clinical support network that's in place. So I'm going to give a quick overview of the vision. It's safe to say that I am not the director for the NHS app. I've previously had that role on an interim basis, but my role is very much in terms of some of the elements that you'll see down at the bottom of the slide. I'm happy to talk in quite a bit of detail about those. That's a question shortly. But I am part of the leadership team that kind of is heading up some of the thinking around the vision for 2030 on the NHS app, and happy to talk to you in more general terms about the vision for that, what's actually been built, what's been prioritised for 26-27, and how it links in with SPR. So as you can see from the slide, it's quite busy. I'll share the slides afterwards, but as you can see from this slide, there is an awful lot of ambition. You'll have seen that reflected in the 10-year plan around what the NHS app can do. And the headline phrase really is that the NHS app wants to move from really being an administrative portal, which it's done to a reasonable effect in terms of the number of people using it every single month. And we've got some really good statistics about how much it is used and what the feedback on that looks like. But this is much more about moving from a state of patients being able to do point-in-time administrative functions to the ability for it to become a companion. What does that really mean? Is it just a buzz phrase? Well, the concept is, the idea is to guide people through real pathways that are digital by default. So in other words, how can we, where it's appropriate and where people choose to do this is not being forced upon them, how can we allow people to engage with their health? How can we allow them to engage with better triage systems? How can we allow them to have better access to a richer patient record, including elements of a personal health record? And how can we better steer them into the physical services on the ground? So you'll see some of the key things here about my care, around what does that look like, around hypertension management, around kind of the access to apps, etc. You'll see things around services locally, across the neighbourhood and indeed into the acute sector. So more information, better, easier to find what it is that you need. And increasingly, this is going to be really important to support services like Pharmacy First, the development of neighbourhoods, Already, there's a significant amount of work, as you all know, in terms of third sector and the work that goes on in the community around supporting weight management, around mental health, around many of the components that we need to knit together and better support through neighbourhoods. Also, the ability to have typical digital experiences. A lot of the work that's going on in the background with the NHS App is to actually move a lot of the code to native. What does that mean? Well, at the moment, the NHS App is realistically a bunch of web pages that is put through a standard format. And what that means is it doesn't have the power and capability of a native app that's on your phone. It doesn't utilize a lot of the features of the phone's operating system. And that means it loses some of the functionality that many have come to expect in a modern digital app. So things like the ability to track, the ability to use AI to have a conversation, for example, use natural language to query some of the information or find the thing that you need on the app. But also things like the interface is a little bit tired and a little bit old. And again, the native experience is going to be important to that. It includes things like the screen on the right-hand side about video calls. So there's an awful lot going on. There's programs that back each of these things up. This isn't just vaporware. So the work behind the scenes on things like the AI health coach builds on the foundation of the Better Health apps and is building a conversational layer, just as you might get in a third-party product like a Fitbit or an Apple kind of fitness app that gives you a sense of your data in context and starts to make it more attractive, more personalized, and frankly, just a bit easier to use for people to engage with that content. Once that content's been really successful, many, many people have used it. People expect a lot more from their apps these days. You can see down at the bottom, and I was talking a bit more detail about this, and I'll do a quick illustration of how we're thinking about this practically working, is digital diagnostics. So the ability, for example, to take your blood pressure on the NHS app, not necessarily fully medical grade device territory, but certainly as what I would consider a gateway product or an ability to engage people in understanding their numbers around blood pressure and then handing them off to a pharmacy, for example, to do a blood pressure check and get a confirmatory diagnosis if that's what they need. So the idea that we're starting to draw people in with technology and actually use it as a triage mechanism to hand into existing pathways in the NHS is a really attractive proposition we're going to be testing out. Digital therapeutics, there's a huge amount, and I'm sure many of you involved in innovation networks will already be involved with these apps. They work well when they are carefully implemented locally, and there's an awful lot that goes into the conditions for success locally. We've done recent studies on what this looks and feels like right across the country, from Frimley down to Dorset to Yorkshire to the northeast, to really better understand what needs to be true for these digital apps, which are of a medical grade device. So they are class 2A and above typically, rated by MHRA. They're also approved by NICE in terms of their clinical and financial efficacy. And we've got a bunch of innovators who spent, in some cases, up to 15 years developing these products closely with clinicians, with patients, with commissioners. And they feel quite frustrated that we've got an innovation gap, a gap between the development that they put forward and the market as it stands today in the NHS for these not being well supported, short funding cycles, a lack of investment in training and skills to really uprate local digital capabilities, really support patients on the ground to onboard to these, and also support them in the use of these pieces of work. Just buying licenses for these products and sharing them out doesn't work. We know that. So there's an awful lot of thinking and work behind the scenes to understand the operating model for how these digital therapeutics can practically work as part of a real pathway, an integrated pathway. And as I said, there's some fantastic examples of where people have cracked that code already. I think it's important to say at this point that none of this is about the NHS App or the centre being a startup. That doesn't work, in my opinion, and in many people's opinions at the centre. This is about the centre acting as a scale-up mechanism. It's about trying to take out some of the barriers to scale that we've perceived in the market and some of the barriers to innovation. So really important that we're not there designing these things from scratch. We're learning about innovation where it's worked well, and we're trying to understand the recipe for success that we can then codify, whether that be through national tariffs that we can build, which we're working on in the background, whether it be through digital infrastructure, whether that be through really market regulation and improving the offer that these companies bring to the table around training, around prices, around quality, etc., and the integration of these products so that we can switch them out and there's less kind of vendor lock-in. There's an awful lot we can do in that space to try and help along the way, but we can't solve it alone. National scale at-home testing or at-home self-sampling, I could talk more about that. The wearables and health sensors aligns really well with digital therapeutics. It's more of a thinking around how can we start to utilize that data. And it's not just about plastering these devices over pathways, because so what? Why does that really change the dynamics and the outcomes for the patient? It's about working closely with clinicians to understand, and patients, where it makes a real difference in their journey. So is that as a gateway product, as I talked about right at the start, in terms of triggering people to take action and moving into an NHS pathway, being triaged carefully so that we're not overwhelming GPs with pings on Apple Watches? What about when it comes to annual review? Is a GP realistically going to want a year's worth of heart rate data? No, of course not. But how do you summate that data and make it contextually relevant to that review without a patient having to verbalise that or write it on a piece of paper? And then we'll come to things like the patient-controlled PHR, so the idea of a full personal health record and curated wellness apps that sit behind that as well. Let me come back to the more immediate future, which is about, so what's happening in the background to kind of build the foundation for this. So as I've alluded to already, the NHS app is kind of put together a little bit, don't quote me on this, with sellotape and string through these websites amassed under the banner. And to an extent, it's outperformed its capability. It has 30 separate integrations to separate companies to provide a lot of the facility that sits behind it. But in order to really have that experience, that digital experience that many private health apps already offer in many ways, the NHS app needs to fundamentally rethink its architecture, the way it's structured. It wants to move alongside a lot of the work in the 10-year plan to a digital by default approach to offering services. What does that mean? It means that just in the way that the NHS has looked at things like retail and banking, it wants to offer actual healthcare experiences within the app. And there are lots of fantastic innovations out there already providing these services to patients. The NHS app hasn't taken on the job of curating those and offering them to patients. For example, what it does at the moment with Wayfinder is it gives patients the facility, and 7 million patients use it every month, or 7 million users use it every month, is the ability to book appointments, to fill out questionnaires, to ask questions, single point of contact. There's increasing facility in there, but there isn't the ability, if you're on a PIFU pathway, a patient-initiated follow-up pathway, for example, to access an app that can help you wait well, that can help you stay healthy, that can help you manage long-term conditions, etc. And there isn't the ability to easily do things like video calls as follow-ups for a PIFU. So there's quite a lot of work going on to kind of structure and enrich the experience for what you can actually do around self-serve to actually make it more practical and more beneficial. We also want to empower patients with a doctor in their pocket. It's a bit of a buzz phrase within the NHS app, but what does that really mean? It means enhancing things like AI triage and really improving the experience around urgent care. So there's 3 core flagship propositions in the NHS app that are being worked on. A lot of the work that I've already described fits under these 3 in a way. Using AI-assisted triage models, which are already in development, have been in development for nearly a year now, on data-driven pathways. The richness of the single patient record is going to be critical to helping understand how we get more from AI-assisted triage models. Without that context, without that understanding, these things will not respond to the complexity of the patient's case. We know that it's very difficult through the questionnaires that we have in the NHS app for patients, for example, to remember what medications they're on, what allergies they have, what comorbidities that they might have, and the names of them. And so when it comes to utilising the single patient record, actually taking as much as possible from that single source of truth to pre-populate and provide context around the decisions that we're supporting the patient to make is going to be critical. Transforming planned care, I've already mentioned about the shift from outpatients, things like the PIFU pathway, etc. But this involves really the use of things like home testing, digital therapeutics, increasingly video calls and PIFU and SIFU, so remote monitoring. And also managing my health, empowering people to manage their health and the health of their dependents as well. So this is very much looking at that shift from treatment to prevention. It's looking at how can we get better at early detection and the ability to manage people and their risk factors early on. I'm not going to go into too much detail on the slide because I'm conscious of time, but we've got things like digital communications, adoption of ERS APIs, electronic prescribing, and also things like the management of appointments. There's an awful lot of work going on in the background to try and bring more standardization to appointments and referrals that sits behind the scenes that is kind of a key enabler for a lot of these experiences. I've talked about, or touched on at least, the three kind of big areas in my portfolio around home testing or home self-sampling, health store, which is the title that's in the 10-year plan, but essentially read digital diagnostics and therapeutics, medical grade software that is deployed and supported via the NHS app to make it an easier user experience, and health sync, which is all about the ability to capture relevant information about the patient, but serve it up in a clinically relevant time, in a clinically relevant format. I'm going to finish on this slide, which is a bit of a sneak preview of something that is likely to feature in the CVD Modern Services Framework, now due to be published at the end of May. The ambition of the Cardiovascular Modern Services Framework is to really put together all of this innovation and all of this thinking into what is the articulation of the future of these pathways for a patient, for clinicians, and for the health system at large, and indeed the economy. What will it actually do? What does British healthcare, what does the UK healthcare system look like in 5 years' time, recognising some of the big challenges that we have? And some of the how, you might argue, needs to be better thought through. I think we've got quite a bit of that behind the scenes. But this is a bit of the what. This is an articulation of what the journey might realistically look like for some people, if not many people, by 2029 in the NHS. So I won't go through the whole story. You can read it in your own time. But you can see here what we're attempting to do is to articulate tools that are there today, tools that are close to being deployed in the context of new models of care like neighbourhoods and new facilities like video call reviews and PIFU, remote medication titration in a journey. So this is specifically about CVRM or CVD, renal and metabolic health. Recognition from the CVD MSF that some of the health checks that we have in place at the moment or some of the touch points in the NHS aren't broad enough. We're simply not capturing enough of the cardiovascular disease early enough and then treating it quickly enough to prevent downstream impact. And yet it's one of the areas that we know we can have the biggest impact. So here Abdul's story articulates how you might utilise the single patient record and utilise AI on top of that risk stratification to get a better sense of the patients that we need to target. Also, how we might then share some of that biometric data, how we might use neighbourhoods to really engage people. And there's a hybrid journey here that includes digital elements and local support. How we might then encourage people to manage their conditions and also monitor their risks on a self-serve basis with the support of clinicians in the background. And it's fair to say that there's nothing on this page, although it may seem a little bit far-fetched, that couldn't actually be set up and run in the next 6 months from a technical point of view. The real challenge, as always, is making sure that this fits in with real clinical workflows, with pressurised clinicians, with a lack of clarity around funding, commissioning, etc., etc. All of the usual challenges, the ones that we're used to. They're not insurmountable, they are difficult. So I'm going to pause there, conscious of time, and really happy to take any questions.
Thank you so much. I mean, it really paints a really inspiring kind of perspective of, the future of the NHS app and how it will transform, how we support our patients and how people are really at the centre of their care. I'm sure there'll be lots of questions. I've got one which you've kind of answered for that final slide, which was particularly lovely to see, given it was cardiovascular disease prevention. But how do you prioritise? There are so many different things, so many different opportunities that you've painted. Where on earth do we start with, working through the opportunities, and how are you approaching it?
Yeah, it's a great question. There's a backlog of over 75 different services that the NHS app is currently triaging and trying to process. I think the key thing is those three pillars that the NHS app has set out for its vision around becoming a companion. And what does that realistically mean? It wants to have a better triage engine at the front end. It recognises that whilst 111 works in some scenarios, it doesn't work in all. And actually triaging that demand to the most appropriate place is going to be critical for the future of the NHS and for the NHS app. Secondly, how do we really support that shift? We've talked about shifting out of outpatients, the outpatients model, for quite a while. Curved has been around for many years and done a good job locally. But if we're talking about being able to do that at scale, that becomes extremely difficult. PIFU pathways are, in some specialties, quite popular and working well, but the ability to support that with real infrastructure doesn't really exist. Critically, what doesn't exist is the tariffs for digital health that really make this a viable proposition for organisations under significant financial pressure. So the technology that I've presented to you today is part of that prioritisation, but a lot of the prioritisation is trying to fix some of the conditions for success underneath. There's no point in plastering lots of new features and technology over the top of this if we can't solve some of those fundamental problems. So that's a lot of the work that's going on in the background.
Thank you. AC.
Thanks, Laura. Thanks, Martin. I think a brilliant presentation, and I'm delighted to sort of see some of the developments. I think partly to give a bit of background, I'm speaking next on sort of inequalities and digital technologies, and we set up this series precisely for this sort of conversation, working with Laura. I had two specific questions, because at the risk of sharing some of my presentation sort of element ahead of time. One of the key studies we did, or I was sort of involved in between 2018 and 2021, was a large-scale evaluation of online consultations, eConsult, in the Southwest. So we looked at sort of lots of data, experiential analysis. And one of the key recommendations was the NHS app being the front door. So it's really good to see that. The challenge there, of course, is user experience. You have just sort of touched upon the multiple opportunities that an app like this could have, what that means for an end user, and how would they navigate this. So the first question I had was, is it something that would be orchestrated by regions or neighborhood? Because you'll have a set of services that work with your workflows. You don't want to expose and complicated interface to the end user. So how would that sort of roll out been thought about? And I'm just mainly thinking about your comment around how this is sort of looking at commercial perspective. So the Germany's digital gateway sort of initiative,
DiGA.
Is that something of a model that is in mind for integrating that as well?
Yeah, basically the health store is the UK's version of DiGA, and there's some real challenges with DiGA in Germany around. It's all well and good having that proposition up there, but actually some of the financial flows that sit behind it around the insurance system over there hasn't quite worked. So whilst it's great to have what we consider our first pillar, we've got a 5-pillar operating model. That's about the regulatory element. There's the funding element is the second pillar. The third is around commissioner choice and visibility, about matching the right product with the right local need. There still very much needs to be a local voice about how these products really fit in. The fourth is around the user experience and how we guide people and support people and provide a support wrapper around individuals, because just giving people a text message and expecting them to onboard and use these things we know doesn't work. So that's where the companion element of the NHS app as a front door, but as a guide and a port of also safety to come back to if things aren't working, or I want to scream that I don't know how to use this app, for example, which we know is a real issue. Actually bookends that. But critically, the fifth pillar is about what needs to be true on the ground. What's the recipe for success? or at least what are the ingredients? I think it's really important that we don't specify the recipe for success on the ground, that is locally derived, but the ingredients that are common to successful deployments of these technologies needs to be appreciated at the centre, and barriers need to be reduced. When it comes to user experiences, the key thing is to provide a standard, easily accessible experience. That's what the NHS app is pretty good at. It is not perfect, but it uses really good standards around accessibility. Where it becomes more complex, that's where we may need to hand off to local services. For example, we're building a HIV testing component within the NHS app at the moment, but when it comes to more complex requests around contraception, around PrEP, around T4 panels or multiple panels for sexual health, we'll hand off to the SH24 or Preventex websites that patients use today. But the problem has been getting to those websites and understanding how to order a test is extremely complex and varied. So trying to provide that standard gateway to improve accessibility, but not losing the richness from some of the services behind, is a balancing act. But I think it's an important one. It's the same with digital therapeutics. And just picking up on Sally's point about how are we working with private providers, good example would be, it's all well and good building these apps and having the handoff points from the NHS app to, let's say, MyCOPD or Sleepio or whatever it may be, but we don't get a lot of this data back at the moment, and we need to build the infrastructure for that. So we're setting standards around FHIR. We're making sure that everything's FHIR compliant. We've got something called the PDM, which is the patient data manager, that sits alongside the single patient record, that has all of the things in that you can't really put into a clinical record or wouldn't be appropriate for now. Ultimately, we have a plan with the SPR team to think about what that wider personal health record looks like. So that could be biosensor data, it could be preferences, it could be care plans, it can be a whole variety of these extra elements that have typically stood outside of the care record, but need to have some sort of linkage into the broader single patient record as well. I'm conscious of time. I don't want to burn too much.
Thanks,
one more question. We got Caroline's waiting patiently. Caroline.
Hi, I'm Caroline Angus, Head of Innovation in Norfolk and Suffolk ICB. Really interesting presentation. Thank you, Martin. What's interesting, particularly around your CVD elements, is we've started to do quite a lot of thinking around that locally, around an integrated end-to-end digital pathway, and have reached out to your product and development team, I think, as well. So what I'm interested to explore is how we broaden or narrow and work collaboratively between what's happening locally in terms of embedding this as part of a transformation pathway alongside the digital elements that can be led through that NHS app component. So really interested how we bring all of that together and work together on some of these great opportunities.
Yeah, so firstly, Caroline, I'd really welcome the opportunity to do some thinking together on this, and for us to hear some of the reality of some of the bumps in the road that you've had to date in even getting to where you are today, but also the support that you benefit from in terms of scaling this and helping it move forward. So firstly, let's connect after this and let's make sure we can set some time up with the team properly. I think for me, the key thing is these things have got to work in practice. There's no point in having these wonderful digital models if we don't have the models on the ground to deliver them. So it has to be fed from the bottom up. Let me be plain. The CVD MSF will be a dusty document on a shelf if it isn't informed by real practical models of care. And there are two documents. The first is the publication in May, which is the CVD Modern Services Framework. I think there'll be some scepticism about that. But the second document that will come out later in the year, scheduled for something like August, September, will be the implementation guide as to how practically we think. And it's the featuring of the work that organisations like yourself are doing in that implementation document that will start to really put some flesh on the bone about the how that's going to be critical as to whether this really works or not. There's real ambition for digital by default pathways. I don't think there's many people at the centre who've lived and breathed that journey to understand exactly what needs to be true, which is why we need to work with people like yourself.
Brilliant. Thank you, Martin. Look forward to speaking to you later.
Thanks, Caroline.
Martin, thank you so much. That was absolutely fascinating. Really enjoyed your presentation. So a huge thank you, and thanks for the information about the implementation, guys. That's super helpful and encouraging to hear. So big thank you. Mohammed just asks about where we can read those 5 pillars, Martin. So if there's a way to maybe put a link in the chat or send it around with the slides, that'd be really appreciated.
I'll drop the single slide into the slides and we can ping those around afterwards. But yes, of course.
Excellent. Fantastic, brilliant. Well, thank you so much. I'm now going to turn to AC to talk about some of the research, extensive research she's conducted around the use of electronic systems to book appointments and so on. So AC, over to you, if that's okay.
Thanks a lot, Laura. Hopefully you can hear me now. And you can see the slides as well.
Yes.
Brilliant, thank you. I think that was a good sort of, I guess, wedge into my sort of slides. I'll try and focus on inequalities and inequalities research, not just about my own sort of research, but also across UK, Europe, and US in terms of where we are seeing sort of similarities, because as Martin said, we are in a stage where we are scaling up. So just to give a bit of context, my personal background is I'm an academic at the University of Leeds, Professor for Digital Health and Education and Dean for Digital Transformation, but I have also two sort of NHS roles in the West Yorkshire ICB and at a sort of trust in Devon, chairing the EPIC, sort of shared EPIC implementation program board. So there's quite a bit of varied experience around academia, research, and commissioning and sort of implementation. So what I wanted to take you through today is where sort of we sit within health inequalities and specifically thinking about over the last decade, what published evidence base shows that technologies can reduce health inequalities, primarily by expanding access to care, sort of lowering time, cost barriers, improving monitoring, follow-ups, everything. Quite a bit of that was touched upon the previous presentation. But the key element that I want to draw out is these benefits on sort of reducing health inequalities are only derivable when implemented with explicit equity design choices, where we have multi-channel access, sort of cultural adaptations, and navigational support, implementation support on the ground, enhanced infrastructural and device support, better service workflows, the clinical pathway integrations that do not penalize those who cannot use digital routes, for example. So there was a systematic review done in US populations experiencing health disparities and found that digital hypertension, if clinically sort of managed and meaningfully reduces systolic BP. So there are sort of significant evidence in the literature, and after the session I'll share the slides where you'll see all the references at the end, where digital technologies has been used effectively to reduce inequalities if well designed, and across the globe, not just in the UK. However, at the same time, within the same sort of time frame, let's say about 2016 to 2026, there has been enough evidence to also show that digital first shifts can widen inequalities, and we'll cover some of those today. Just to set the scene, I think, and bring everybody on the same page, it will be useful to understand what the reference point is in terms of health inequalities. What do we mean here in terms of inequality? So it's primarily I'm referring to access inequalities, utilization inequalities, quality and process inequalities, and outcome inequalities. So it's a quite complex landscape with multiple constructs we are trying to track, mainly to look at outcomes between sort of population groups, which represent socioeconomic, demographic, geographic, ability, language, and other dimensions. What does that, and equally for digital technologies, what does that mean? Sort of, I think, again, we have touched upon telehealth, remote monitoring, and online consultation through the previous presentation, but there are other areas in terms of patient portals and algorithmic AI and the digital therapeutics, where digital technologies. So framing where we are sort of looking at digital technologies as a cumulative area of these particular applications within health. So what does that sort of, as we've set the context, what does the literature tell us? So looking at telehealth and remote consultation first, telehealth's equity promise rests on sort of reducing distance, travel costs, time costs, especially for rural remote populations and people with limited ability. European evidence includes a national French study showing sort of teleconsultations were used substantially more in medically undeserved areas and non-undeserved areas with rapid access, consistent with the role of improving access where clinicians are scarce. UK evidence shows sort of rapid pandemic-driven expansion, but with mixed equity implications. A large EHR analysis of 19 million adults found remote consultations increased markedly during COVID-19, understandably so. But patterns varied by deprivation and ethnicity. And what was looked at, that pattern and gradient shift pre-pandemic, post-pandemic shifted, including a documented reversal in odds by deprivation. A persistent ethnic differences between white patients most likely to have remote consultations, while Asian, Black, minority patients having smaller or relative increase in online consultations. What this points to is a policy reality. Telehealth expansion does not automatically equalize access. And I think that's a key takeaway that we need to sort of look at through the evidence. It can help reach underserved geographies through phone, video, etc., but can also reproduce inequalities through digital access. Enhance sort of language barriers, service redesign that unintentionally advantages digitally confident groups. Similarly, in the US, sort of mixed, it points to a mixed utilization level. A US cross-sectional study examining telehealth, telemedicine among adults versus most sort of socially vulnerable countries highlights that digital healthcare use was varied by indicators of disadvantage, and emphasizes digital health literacy as the key correlation. So digital health literacy is significantly important through community interventions to maximize equity and utilization of some of these tools. Thinking about sort of remote monitoring. Again, remote monitoring can reduce inequalities, and again, the best inequality sort of evidence in the US comes from a multi-component RPM tool around sort of hypertension for underdeserved populations. There's been quite a few systematic reviews to point towards it. UK evidence similarly sort of points towards similar differential engagement. EU evidence is also mixed as in terms of some looking at telemonitoring programs, some benefits of scalability, equity impacts, and really measured sort of cost effectiveness. So there's a mixed bag of approach there where you can see there are significant opportunities and challenges in the same breadth. I mentioned our own sort of evaluation in the Southwest. So there's the paper published in PMJ. We looked at rollout of eConsult. There's significant sort of benefits, concerns, drawbacks that were sort of reported. One of the key findings there was in terms of utilization across groups and need for further research on to understand why that is. There were some sort of assumptions made, but the previous sort of presentation validated some of our recommendations, and one of the key elements of access we found is GP practice websites being so varied and inaccessible. They were designed by a few companies, very poor UX, good luck finding services on how you can access online consultation. So our recommendation was to use something like NHS App back in 2021. So it's great to see significant progress being sort of made in that particular space. However, one key important thing was to ensure that it's designed for everyone and how the access is managed, and most importantly, complemented and supported for uptake for various demographics and patient population, which should be then, as I think Martin was mentioning, fine-tuned by local, regional, and perhaps even to the neighborhood level. And if the NHS portal or the app allows that customization at a regional, sub-regional level, then I think that will be ideal. So that BMJ paper sort of gives quite a bit of insight in terms of usage across online consultations. Next, if we just look at mobile apps, digital programs, and therapeutics, where that sort of what the evidence tells us. Evidence for apps that delivered programs is strongest where digital tools are embedded in structured clinical pathways. Again, we just heard in the previous sort of presentation that's so important to ensure personalization and support. In England, the National sort of Digital Weight Management Program evaluation provides an example of a large-scale digital intervention showing clinically meaningful average weight loss at 12 weeks. Results suggesting weight reductions were not dependent on deprivation quintile, and that's important. So because I think this was, if you read the evidence there, it's potentially linked with proactive triage of participation into high support levels. Because this is a very important design lessons. Differential support intensity can compensate for sort of differential digital readiness. So as we are planning some of this large scale left shift implementation from sort of cure to prevention, the differential support that we offer will vary from every neighborhood to cope with digital readiness. And I think that's a key message that we should take from that sort of NHS England study around digital weight management. Equally, on the other side, sort of the broader evidence base indicates standalone apps effects tend to be modest and are threatened by engagement drop-off. And again, lots of innovators, we have seen this so many times, especially among users with low digital health literacy, limited time or completing or competing socioeconomic stressors. Equity relevant implementation, therefore, typically requires, again, repeating what was said earlier, simplified UX, multilingual content where it's viable, proactive outreach, extensive proactive outreach, to be honest, and low friction onboarding, often using sort of navigators or warm handoffs rather than expecting self-start. This has been very successful in the US in some of the larger sort of rollout of digital hypertension tools, where navigators play an absolutely important role. Again, we tried something with this, and every region has lots of medical nursing schools, and you can use that student population in their placements when they're going in the placements to build a program of activity to act as navigators for a new service that's been rolled out. We have tried that again in the Southwest and in West Yorkshire in smaller scale, but something worth contemplating. We can't not touch AI. AI can reduce inequality when it sort of removes bottlenecks in care pathways. In a sort of positive spin where it sort of disproportionately affect underserved groups. A strong example of is autonomous AI diabetic retinopathy screening in youth. A randomized trial reported 100% completion of diabetic eye exams in the intervention arm versus 22% in control within 6 months. Described as closing a care gap in a racially and ethnically diverse population. Again, I'll share the reference at the end of the slides. Yet the most established sort of AI and equity evidence in the decade highlights the opposite risk. Algorithms can scale inequity because a lot of those algorithms are trained on data that might not be equitable in the first instance. So it's already sort of skewed, biased against a certain population group, which is where it's fairly important that the implication is not to avoid AI, but treat equity as a safety requirement. So when we are procuring, where we are evaluating, where we are commissioning sort of AI-enabled tools to integrate with any front doors, it's fairly important that subgroup performance auditing happens. There is enough evidence around bias mitigation, there's clarity around data governance, as well as sort of post-deployment monitoring for clinical decision pathways where AI is integrated, because it's not something that stays, because it learns, changes, and adapts it. adapts. So how do we monitor it on an ongoing basis is fairly important. We also mentioned sort of EHR portals. One of the bits that I was not able to pick in the previous conversation with Martin was, it's great to have the NHS app. Quite a few of the large-scale EHRs have their own portals, patient portals. And the more interfaces we have, the difficult it is it's difficult for the end user to manage the continuity of care. So I think there is an opportunity to explore how do we actually get some of these large organizations to integrate with the NHS front door, the NHS app. Again, EU evidence repeatedly finds sort of pro-rich, pro-education patterns in e-health use. A systematic review cites towards lower association of e-health services with older age, lower education, lower social economic. Again, this is not any new news, to be honest, because it's just of reinforcing what we already know. In Finland, for example, a survey research during COVID-19 examined non-use and dissatisfaction with National Patient Portal. They have a national patient portal called MyKanta, focusing on sort of socio-demographic characteristic, digital skills, and experience of guidance, highlighting that even among people who used the internet in the past year, digital divide factor skill support remains central. Again, there's a similar sort of evidence in US I mentioned in terms of how push portal activation and usage with notable increase among sort of socioeconomically deprived communities help with navigators. So increased using the navigator period subgroup increases were statistically significant. So the more support we can provide to those groups which are at risk of lower uptake for a longer period of time within neighborhoods through sort of volunteer communities, student population, the better chances of adoption and utilization of some of these services. Just checking how we're doing for time. So let's just final two slides. So we've touched upon how digital sort of widens inequalities because of course, and some of the factors. So we have touched upon some of these areas, but for policy and practice perspectives, I think it's very important to make equity by design mandatory. So it's non-negotiable really in terms of how health system should require that any expansion of digital access should have multi-channel approach with equity impact assessments and mitigation plans. We have to try and ensure that there's suitable funding for digital inclusion and also ability for sort of commissioners to reimburse navigator functions or equivalent support. Again, we need to look at sort of international examples and learn from it. So DIGA was mentioned from Germany, for example, where some bits work, other bits didn't work. Prioritizing high-yield equity interventions. If resources are constrained, which are always constrained, remote monitoring plus human support for high-burden chronic conditions is in underserved groups gives stronger outcomes. Similarly, low-cost digital outreach, as simple as SMSs, has been seen to be so effective, where follow-ups and sort of screening vaccination programs have the biggest evidence of being successful. And finally, looking at sort of health literacy as a key, digital health literacy as a sort of key enabler, ensuring that we prioritize easier sort of pathway design and sort of equity metrics are integrated well into operational KPIs, both for providers and sort of ICBs to be tracked longitudinally over a period of 3 to 5 years, because some of the shifts would take longer than anticipated. So I think we need to keep a close eye through sort of the performance management on integration of some of this app. How are you doing for Laura? I think that's the final slides. If I can take.
Yeah, but probably at the end there's probably a couple of questions, but thank you so much. I'm really interested in the equity outcomes and how you include them in procurement chains and how that needs to be a fundamental minimum. So yeah, we'd love to hear more about that. But there is a question, well, a comment in the chat, and Zoe, I don't know if you want to unmute to talk about the concerns around the environmental impact of AI and digital almost being a barrier in itself with people engaging, and whether that will be a problem in the future.
Yeah, it's more a comment than a question, just that with the movement towards digital interventions and digital-based and AI being naturally integrated, there's no choice that people have, and there is a lot of concerns, I suppose, for the environmental impact, and I would say the data that's being put into it, but they did not comment on it at this within this context of the conversation, but they were absolutely adamant that I was not to use it for the purposes of doing that piece of work.
I think that's absolutely important, and quite a bit of conversations happening in this, as we are again as part of that procurement process and several sort of climate and green plans for systems. It's really important to ensure how some of those AI or digital tools are being sort of supported. So, for example, at the university, we have a huge investment ongoing around high performance computing and AI, looking at infrastructure. So there are choices that we can make to ensure that these are all sort of green compliant. So looking at sort of data centers which use as much as renewable energies, sort of renewable sources of energy, is something that you can gradually integrate against net zero plans each organization have. So I think there are ways in which we can start looking at them, sort of mitigating some of those concerns. But that's a real concern because every time even anybody types a single prompt on ChatGPT, you're contributing to the broader sort of CO2 emissions. So how to be mindful as we start using AI tools in future will be fairly important.
Thanks so much. Final question, Mohammed, your hand went up as AC was speaking. I didn't know if you had a question or wanted to come in.
I was asking about some of the nuance, but the professor went through it. I just would love a copy of the bibliography for the research. It was so incredibly helpful. Thank you for that.
There's a huge bibliography, so I didn't sort of say, because the whole slide will get too busy otherwise, and hence I left it out. I'll share it.
That was the one I was looking for. Thank you.
AC, thank you so much. We'll circulate the slides, including the bibliography, because some of those resources have been incredibly helpful. So thank you very, very much.
And I've already shared that sort of PDF file that we created with effectively Richard Stubbs commissioned it about 5 years back. So I think that is something fairly important for everybody to consider as you procure some of these applications. Thank you.
Excellent.
Thanks, Laura.
We'll circulate that as well. Thank you. So our final speaker before our break is Swati from Kidney Research UK. And two things to say. Swati's quite unwell at the moment, but she's kindly agreed to speak, which we hugely appreciate. And Swati and I had a conversation a couple of weeks ago about some of the things, the wider things we need to be aware of. And the use case there was patients having been coded with chronic kidney disease, but not realising that they had been diagnosed as such until they saw their information in the NHS app, which prompted a bit of a conversation about what needs to change within our health service to be able to accommodate, this access to information. So I will pause there and hand to Swati. Thank you.
Thanks so much for the invitation to join this conversation. To save everybody, I'm going to keep my camera off because I am, as she mentioned, I'm not feeling very well. Can I just ask, are you happy to share the slides, Laura? Do you want me to do it?
We can share them our end.
Oh,
Maria,
perfect.
is that okay to do? Thanks.
I'll just tell you to
give us a moment.
Yeah, no worries. So I guess just a little bit of background about me. I lead on the multiple long-term conditions area of work within Kidney Research UK and have been in post for 3 years. It's a strategic priority for the organisation to think about the other drivers that lead to CKD, so predominantly diabetes and heart disease, so raised blood pressure. Clinically, I'm a physiotherapist by background, having worked in the NHS for 25 years, which I feel really does show my age. But the other hat that I wear in my job and in my day-to-day life is expert by experience. So I'm a carer for someone that lives with multiple long-term conditions, which is my dad, and I have done that for the last 20 years, and I navigate the NHS on his behalf. And I guess I'm going to bring the realness of and the challenges around digital, moving towards digital, especially from the space of a carer, where accessibility is a huge problem when you've got someone who is advocating and supporting somebody that lives with multiple long-term conditions. So next slide, please. So one of the things that I whenever I speak about this role and what I do in this space is it goes back to patients. So something that I did when I first joined this organization was really reach out to patients to ask their experiences, and did a bit of a thematic analysis on what came out from patients' understanding of living with multiple long-term conditions. And one of the things that was really clear was there's a huge issue specifically with CKD, but its drivers, so hypertension and diabetes, and there being this feeling of stigma and shame associated with developing a complication, even though as any healthcare professional and even the wider public probably has an awareness that this isn't patient fault related. It's not a failure on the patient's perspective, but just being cognizant of that, I think, is so important as we move into this space of things becoming, everything becoming digital, and how that really lands with the patient. So I'm going to go on to talk about, sorry, the next slide, Laura, if that's all right. Kidney Care produced a report at the end of last year, which provided some stark results. I've added the reference in here. So Kidney Care is the other renal charity. And one of the things that came through from their report was patients finding out about their CKD diagnosis, but finding it out via the app, which had huge implications on their emotional and psychological well-being. A lot of this is driven by CKD being a relatively silent disease until it's present, and we're trying to avoid patients ending up in end-stage renal failure. Some of the pushback from this has been around patients not having any symptoms, but then being coded. And this was one of the points I raised at the meeting where I met Laura and her team, was we've had some patients feed back to us that actually they don't want a diagnosis of CKD because they feel well, and it's negatively impacted their ability to get travel insurance or health insurance. And I think sometimes the nuance of the intention is correct. You know, early detection is a key priority for us as an organization, but also with everything that is happening with the 3 shifts, and really giving patients agency in this space is really important. But we really need to strengthen our digital safeguards, because we can't have another patient that finds out via the app that they were diagnosed with CKD. And from my understanding and from speaking to GPs, the coding part is so essential. It absolutely has to happen, but the loop needs to be closed to make sure that this also involves an informed conversation with the patient, that they are aware of what early detection looks like, and that requires time and resource. And I think one of the things that the NHS app and generally, especially in primary care, need to be better at is utilising the voluntary and third sector to signpost to trusted and reputable organisations for providing more information, so that patients at the first sight of a new diagnosis are not going down AI or Dr. Google to try and find out what this actually means for them. And that is a position that the third sector could absolutely support in. Next slide, please. So this was an interesting paper that was somebody that we funded, a GP based up in Manchester, that again the reference is on the slide, around the benefits of coded and uncoded CKD. it really showcased the importance of early diagnosis for early management. We now have a plethora of drugs that are available, as well as lifestyle measures that can be used to slow the progression of CKD. So again, the intent is absolutely correct, but this needs to be balanced with information being provided to patients as part of their diagnosis of a long-term chronic condition. And there are examples, again, pockets in up and down the country where things have been utilized, such as templates of letters that alongside going on to the NHS app, patients are sent a letter to explain the diagnosis, as well as links to trusted sources, and then the opportunity for, if you would like to discuss this further, there is the clear call to action that you can book in with a healthcare professional in your primary care space to discuss this further. I think the challenge, and this is anecdotally from me from a carer's perspective, is the NHS app is great if you have health literacy and you have an understanding of what your health conditions are. I use it. That comes with me having the privilege of understanding and having a medical background, that I understand what the test results are. I'm able to self-advocate, but not everybody has that privilege. And I think if you intersect that even further with, from my perspective, the role of a carer in this space, yes, we have to be protected by GDPR and confidentiality, but the challenge, and this again is anecdotal based on just my experience of utilizing different services. So there's the NHS app, but for my dad in particular, you can't use that to book a GP appointment. There's a different portal for that. And then if you intersect that even further with secondary and tertiary care that don't use the same platforms, you end up in this mess of a space of trying to navigate, to the point where I've gone old school and my dad has to carry a folder around with him that has got all of his up-to-date clinic letters in it. Because if there's ever a situation of the NHS app and its use, is like, the theory of it is absolutely brilliant, but the practicalities of it needing to be utilized if a patient is acutely unwell in hospital, how are the healthcare providers at that particular moment able to access information across different services? There needs to be an improvement in streamlining from my perspective, but also from what patients have said to us. Next slide, please. So one of the things that we were keen to really try and showcase and talk about is the role that the third sector has in providing useful knowledge and trusted resources for patients. So we've worked closely with other well-known charities like Diabetes UK, Heart Research UK, to reach audiences, to raise awareness about disease progression, about how in particular CKD fits with other diseases. And for the most part, it's been well received, not just by patients. We've also created CPD modules for those working in primary care to help plug that gap around how conditions are related, and the fact that very few patients attend a GP practice or primary care with just one condition. This the aging population that we have in this country, as well as globally, means that more and more patients are going to be presenting with more than one condition. So when we think about the usability and the interface of the NHS app, there needs to be some cognition of the fact that patients very rarely show up with just one condition. Next slide. Again, just some examples of what we've done in this space around giving patients agency. So urine ACR testing, for those that don't know, is one of the first indicators of disease progression with CKD. And we've created a really easy to understand patient video with a well-known trusted face, which is Dr. Kevin Fernando, a well-known GP in this space, patient facing, to raise awareness and giving patients some agency about why UACR testing is so important. And if a call to action that if you live with diabetes or hypertension or heart disease, you can speak to your healthcare professional about the importance of this test. It seems small, but one of the points that was raised earlier on in today's meeting was very much about how do we do this? How do we raise awareness amongst patients and encourage patient activation without adding more work at the door of primary care when we know just how on their knees they are at, as a service provider. So the third sector has gone to some lengths to try and support patients. The challenge in all of this is, unless you're inflicted by a disease, it may not be relevant to you. And the privilege, as I've talked about, which links into the talk that we just had around health inequity, and the assumption that a patient has the ability to prioritize their own health at that moment in time with competing life demands, and that actually sometimes healthcare is a luxury that not all patients have equitable access to. Thank you so much for your time. I'm happy to take any questions.
Tosi, thank you so much. Just both giving the kind of the carer patient perspective, also the trusted resources that are out there to support, but you've really brought to life what Martin had said around, what needs to be in place for the NHS app and other things to work in practice. And so being able to think about the wide implications of who needs to share what information when, how it needs to be streamlined, how do we mitigate for health literacy challenges, kind of really helps with this thinking. Mohammed had asked a question around, is it the app or is it the lack of communication with the patient that's the challenge? Mohammed, do you want to phrase it a bit better than I probably have?
Yeah, sure. Or just the phrasing that the problem was the patients finding out from the app that they have the diagnosis. And I'm just asking, is the problem then finding out, or is the problem that that's the only way they find out? And my worry is people say, well, let's not put it in the app. Let's make sure the conversation happens. And actually, this is the only safety valve for patients finding out what's happening.
Yeah, it's a great question, and I think it's a combination of both sides. And I think if you speak to clinicians, they will say to you, the safety net has to happen, the coding has to happen, and once you code, it leads to a diagnosis. And so it's better to have the patient coded so that all the safety nets are in place around, bringing them back for vaccinations, reminders, all of those types of things. But from the patient perspective, that diagnosis of a long-term chronic condition that may or may not have any symptoms at that moment in time is hugely destabilizing. And it does warrant and need a conversation, but we're using the digital platform as a method to streamline services, to make it easier to access this information, but sometimes at the cost of the patient, doctor, healthcare professional relationship.
Thank you.
Thank you so much, Tosi. I completely appreciate you're on well. So we'll pause there and say a huge thank you. And if you're happy, we'll share the slides and the link to the resources that you've kindly shared. But thank you, and
absolutely.
I hope you get better soon.
No problem. Thank you very much.
We're now going to pause and let people have a short break, rest their eyes, stretch legs, grab something to eat. We will come back at 12:30, so we'll keep the meeting entirely open. After the break, we're hearing from 3 of the kind of innovation suppliers on the marketplace. One Big Picture Medical, and kindly colleagues from SNE ICB will be sharing how they're utilising Big Picture Medical in practice. Then we'll hear from Patients Know Best, and then finally Essential Parents. So thank you so much for this morning. Do keep putting comments and questions in the chat, and if you have a moment, scan this QR code and fill in the feedback form, and we'll see you back here at 12:30. Thank you.
Laura, can I double check my microphone's working?
Yes, it's working.
Hello. It is, yeah.
Evidently. Cool. Thank you.
We'll get going in a couple of minutes.
Yeah, sure. Thank you very much, Laura. Okay.
వాళ్ళొక లంచ్ బ్రేక్ తీసుకుందాం అనుకుంటాం పార్కింగ్ చూసుకో సరే మనం ఆల్మోస్ట్ అక్కడ వచ్చేసినట్టున్నాం
Okay, well, welcome back to the afternoon session of our webinar on single patient record and NHS app. As we've done previously, our afternoon session really focuses on some of the innovations on the marketplace and working with the NHS to demonstrate on how they are delivering or aligned with the themes we've covered today. So our first innovator is Tanya from Big Picture Medical, who's also brought colleagues from SNE ICB. So I'm going to hand to Tanya, if that's okay, as soon as she's there. Is she there, Tanya? I can see Caroline's on the call.
She should be.
Oh, here we go. There she is.
Yeah, no,
I can
I
see
think
her now.
Tanya is here. I did message Tanya, and she had said that she was on the call, so I don't know.
I'm here, Charlotte.
Perfect.
For some reason, I pressed to turn my camera on, and it took me out completely. So I've just quickly rejoined. Had a mad panic then for a moment. So apologies. I am here.
Fantastic. We'll hand to you if that's okay, Tanya.
Perfect, thank you.
I think I'm kicking us off, aren't I, Tanya?
Yes, please, Charlotte, thank you.
No problem. So good afternoon, everybody, and thank you for being here with us to hear about the weight management and complex obesity service, single point of access in Suffolk and North East Essex. And what we're going to share with you today is our journey from a fragmented system to a shared care model at scale. Next slide, please. So my name is Charlotte Minns, and I'm the Senior Programme Lead at Norfolk and Suffolk Integrated Care Board, formerly Suffolk and North East Essex ICB. And I'm joined here today by my colleagues, Mr. Hal Room, who's our Service Lead at ESNEFT, and Tanya Verma from Big Picture Medical. And we're really excited to be here with you today to share our experience with you. Next slide, please. So previously, patients in Suffolk and North East Essex entered weight management services through multiple inconsistent routes, and this created a significant admin burden for clinicians and quite a confusing experience for referrers and for patients, often actually resulting in waits for services from anywhere for between 8 to 15 years to be able to access the right service that met their needs. And this was because patients had to fail upwards. So they had to engage with a tier 2 service, which was lifestyle and behaviour change programs, to access specialist tier 3 weight management services. And they had to engage with those tier 3 services to get to tier 4 services, which is bariatric surgery. And that was being accessed via different kind of referral pathways and routes and criteria. And as I previously said, was creating quite a bit of confusion across the pathway. And there was no scalable triage system to match patients to the right level of care that they actually needed, meaning that access was often determined by the service that a patient had previously engaged with and the amount of time that they had actually waited for that service, and not by clinical need. And NICE Guidance 246 really challenged commissioners to think beyond the tiered model of care. What we found was that information was scattered across multiple organisations, and without a shared care record, there was no single source of truth, leading to often duplication and confusion. So together, these issues created a capacity issue across Suffolk and North East Essex, and our local population health management data was telling us that around 42,000 patients were eligible for specialist obesity treatment, and there was no coordinated pathway to support them effectively. Next slide, please. So we partnered closely with Dr. Caroline Angus, who's the head of innovation for the ICB, to shape and agree a clear challenge statement that captured the scale and the complexity of the obesity pathway issues. And Caroline worked with ourselves and with Health Innovation East to engage with industry innovators, testing how we could or how they could respond to our challenge statement, and by exploring potential solution models. Caroline and Health Innovation East convened an innovation exchange sponsored by our ICB's Deputy Chief Executive, bringing together digital, clinical, commissioning colleagues and integrated care system partners and providers who worked in the weight management space, along with industry innovators, to kind of demonstrate and review various different options that could really kind of begin to challenge those various different models with multidisciplinary input. And following the innovation exchange, we ran a structured procurement process. We assessed various different solutions against our criteria, and ultimately we awarded the contract for the single point of access to Big Picture Medical. Next slide, please. So we established cross-integrated care system design teams, and we held thematic design sessions focused on the pathway workflow, communication, co-production and digital infrastructure. And the teams brought together colleagues, again, from digital, commissioning, primary and secondary care clinicians, local providers, and comms and engagement, and Big Picture Medical. So in these sessions and with the team, we redesigned the pathway to create the single point of access for all of the weight management and obesity referrals, introducing a standardised referral form and singly kind of governed front door across the integrated care system, creating that shared care record. We implemented a clinically governed AI-assisted kind of triage algorithm to scale decision making and ensure patients are consistently routed to the right intervention from the outset. We've established a single source of truth across the patient journey, improving visibility, reducing duplication, and enabling data flows back into primary care. I'm now going to hand over to Tanya, who's going to take us through the next couple of slides. Thank you.
Thank you, Charlotte. So before I go into details on this slide, it really helps to think about the single point of access as three interfaces that usually would sit in different places. So first of all is the referrer and the patient interface. So that's capturing the referral context, the onboarding information, and the ongoing communication. Second is the clinical operations interface. So that's the work list, the triage decision making, the ownership, and the actions that move that patient through the pathway. And third is the integration interface. So that's the connection to and from the electronic patient health record, so that pathway doesn't become another silo in the system. So what Big Picture Medical does is it's consolidated those three interfaces into one unified platform. So on the clinical operations side, we provide a single consolidated work list with the clear status and the ownership and the next steps, with role-based access to the right users for the right actions. The triage decision-making logic, which we'll come to in a moment, is embedded directly into that workflow. So the decision-making is consistent, it's traceable, and it's also auditable while keeping clinicians in control to confirm and also to override if needed. So on the patient referrer side, we provide the onboarding, the baseline questionnaires, the document center, and obviously waiting well support, plus the automated communications like reminders and updates that improves the experience for both patients and reduces the manual administration chasing for teams. So on the integration side, we enable the contextual launch of EMIS and System 1 from primary care, and we embed the pathway outcomes and updates back into that record. So instead of introducing another standalone system, we connect the pathway to the existing ecosystem that's already there and keeping a single source of truth across that journey. Next slide, please. So I'm going to explain a little bit of like what the plumbing, shall we say, that made the SNE Suffolk and North East Essex ICB weight management single point of access work in practice across the ICB footprint. So as we've heard from Charlotte, the old pathway referral, sort of the context really lived in GP records, part of the specialist context lived in secondary care, and the operational sort of truth as to sort of where is the patient now lived in multiple inboxes, local trackers, etc. So that fragmentation is exactly what we see up and down the country all the time, and it's what makes it hard to really triage and to scale and keep the GPs and the weight management teams and patients all aligned. So for the ICB, Big Picture's interoperability layer really connected those pieces so the single point of access could operate as a shared cared record. So how was this really achieved? So I'm going to go through 4 points here. So firstly, we integrated at the front door with the primary care, as we've said. So the referral is initiated from the GP workflow via contextual launch from EMIS and System 1. So the referrals come through one governed intake rather than multiple routes in different formats. That creates, firstly, a consistent data set at the point of referral and reduces the variability. Secondly, we don't just move those documents around, we capture them in a structured information so that data is reusable. That means the referral context, the triage outcome, the pathway status, and all of the changes and key events are reported consistently to the team as a single patient view and a single work list to really manage the demand. And that data remains usable for the reporting sort of downstream into other systems as well. Thirdly, we use an AI tool to accelerate interoperability. This is a Gen AI assisted mapping, which helps translate sort of the local electronic health record data structure into open standard data. So that means it can be reduced time and effort that it takes to integrate into new sources and different destinations. And fourthly, we keep the whole pathway aligned through writebacks. So as a single point of access captures the key pathway events, as I've mentioned, those outcomes can flow back into primary care to create that consistent record of what's happening and the next steps. So finally, because the pathway data is structured and reusable, the ICB can use it operationally for oversight, for continuous improvement, also for tracking volumes and outcomes. And it's also good for sort of routing patterns and where the demand is building. So the pathway can really actively be managed rather than just waitlist led. And the next slide, please. How?
Sorry, it took me a second to find the microphone button. I apologise.
Oh, no problem. Thank you.
So yeah, a central part of the single point of access that we've developed has been the development of a clinical risk stratification algorithm. And this uses both BMI, but also all of 34 internationally recognised obesity-related comorbidities, and also includes the number of weeks that the patient's been waiting for since referral, and any previous intervention they've done, as well as the necessary ethnicity adjustment for BMI for BAME ethnicities. And each factor is given a different weighting within the algorithm based on the clinical impact of the weight management treatment on that comorbidity. All of these weightings are evidence-based and they're consistent with NICE guidelines and the NHS England community tirzepatide criteria, and they essentially allow ICBs to operationalise any particular threshold policy or access policy. But the algorithm goes beyond that by encouraging referrals for any obesity-related comorbidity rather than restricting it to particular priority groups and this sort of thing. And that means really that ICBs and systems can receive referrals and understand the whole of the problem rather than perhaps only seeing part of the problem, as well as the fact that this is integrating into a shared care record across all providers, meaning that systems and ICBs can see the big picture, the whole picture, rather than just individual services waiting lists. The algorithm then applies sequential logic to make a triage recommendation about the most appropriate first intervention based on the clinical risk score. And previous interventions are taken into account to ensure that the patient isn't triaged to the same intervention twice. And finally, the algorithm incorporates an overall throttle to enable balancing of demand and supply to ensure that available resources across all obesity services within the single point of access are used most efficiently and individual services are not overwhelmed. Currently, the algorithm is just rules-based, but it gives a foundation for iterative AI approaches in the future. All algorithm triage recommendations are approved by a clinical nurse specialist to ensure human oversight. Next slide, please. We've had over 1,300 referrals so far since we've launched the single point of access in February this year, and we're already seeing excellent engagement from patients, primary care, and obesity providers across the system. Providers can see patients triaged to their services in individual work queues, but all providers can see the same shared care record for patient questionnaires, referral information, and previous interventions. For the ICB, the single point of access strengthens system oversight, planning, and maximizes the efficient use of available resources whilst avoiding individual services becoming overwhelmed. It provides a tierless approach as opposed to the previous outdated tiered model of specialist weight management. It provides a tierless approach that ensures that patients are triaged right at the front door based on clinical need, and then they are sent straight to the most appropriate first intervention, and a consistent policy is applied, ensuring equitable access for all patients in the ICS. For the providers, it reduces clinical time of grading for referrals. It reduces admin time onboarding patients and ensuring that all pre-treatment referral information and questionnaires are available to service personnel before a patient comes into an individual service. The clinical risk stratification algorithm ensures that patients' needs are matched to the level of intervention provided, whether that's GLP-1 medication, bariatric surgery, or community lifestyle interventions, or indeed the national digital programs. This should ensure that the maximum clinical impact is obtained for the available resource envelope. The shared care record nature of the single point of access also ensures consistent outcomes tracking across all providers throughout the patient's journey, and we intend to report long-term 5-year outcomes for all interventions so that we really get some high-quality outcome data and understanding of the return on investment. Finally, the shared care record nature of the single point of access ensures routes of escalations between providers and continuity of care across providers, with visibility to all providers of the whole patient journey. Handing back to Tanya.
Thank you. Next slide, please. So what we've collectively built together with the ICB is that repeatable blueprint. And the reason we can scale this is the combination of the platform capabilities that I've just mentioned in my previous slides. So combining that generative AI enabled configuration, the interoperability data layer, and the drag and drop pathway build means we can build pathways in a matter of days and make changes within hours. So in practice, what we've built can then create sort of that core pattern. So bringing that single front door, that structured intake, the clinician-led triage, decision logic, service routing, patient communication, and that shared care record with write backs. You can reuse that pattern across adjacent pathways. So that's particularly powerful with cardiometabolic conditions like CVD, CKD, type 2 diabetes, and smoking cessation, because the pathways share risk drivers, comorbidities, and the same operational needs. But it's super important to note that each pathway can communicate with one another. Just because a patient has multiple pathways involving different specialities, it's paramount having that shared record platform, so it's used to reduce duplication and avoid risk of errors in care. We also scale longitudinally within the same pathways, adding features such as image viewers, teleconferencing, and MDT meeting capabilities. So this increases the value without
Have we lost Tanya, or is
the working reference blueprint for the platform designed to both replicate and scale quickly, delivering that shared cared record capability throughout the ICB. So thank you everyone for listening today. Please scan the QR code on the next slide if you want to find out more, and we welcome any questions.
Fantastic, thank you so much. It's amazing to see kind of how Big Picture Medical has been deployed in practice and the impact it's had. Tanya, we lost you just slightly, but I think we got the gist.
Oh, I'm sorry, my internet must have apologies.
I'll just see if anyone's got any questions. Please do put your hands up or ask in the chat. I guess I had one just around the practicalities of setting up a service like this and having to bring in multiple different organisations from across the ICB, and how you went about that, how the engagement went. Did you experience any barriers or objections to kind of working in this way?
I can take this one, Tanya. I think that reflecting on the journey that we've been on, we've had a commitment within our joint forward plan for many years to establish this integrated service across all of these weight management weight management and obesity treatment and support options. I think what's been really key has been around aligning the outcomes that we want to achieve together, so that when things do get tricky or there's kind of tension between the various different partners, because I think within this pathway there are about 8 or 9 different provider partners that are part of this. So aligning our outcomes from the outset and the vision on how we want to work together has been really key. And I think that we've kind of used your standard project and program management tools to do that around logic models and Moscow mapping and things like that, to really ensure that we're living and breathing the vision that we set out to achieve from the beginning. And that's really supported us to, when there have been challenges or tensions, kind of continue to focus on the outcomes rather than individual organisations' priorities and tensions. So that's how we've navigated that.
Fantastic, thank you. Any other questions? Feel free to put a hand up. Otherwise, just a huge thank you to everyone for presenting. It's absolutely fascinating from Tanya, from Charlotte, Caroline and Howell. So a big thank you, and we will circulate the slides.
Thank you.
Well,
thank you for having us.
Thank you very much.
Thank you. That brings us then on to our next presentation. So I'm going to hand to Mohammed from Patients Know Best.
Thank you. I'm just going to try and share my screen. Laura, is the slot for 20 minutes, including questions, or?
Yeah, well, you've got kind of up to 30 because we're running slightly ahead of schedule. So yeah.
Oh wow,
don't rush.
You're very lucky to be running ahead of schedule. That's very but I promise not to take up that much time. Thank you very much for including me in the schedule today. Just thought I'd give some background about myself. This is just me growing up as a child with a rare disease. So my mother, looking after me, learned early on that maintaining good records was critical for explaining to different doctors my situation and why their particular diagnosis might not be correct. It didn't match the evidence that she had about her. So I grew up from learning from my mum the importance of having, well, a single patient record, I guess, to today's point. And then I went to medical school and saw it from the other side of how bad it is for the clinician. I would like to just point out this is quite an old photograph, so it's not a handlebar moustache that you're looking at here. It's just a goatee with low resolution. But as going through medical school, I saw the implications of the clinicians not having all the information about the patient, and also the clinicians having very little time to understand every patient. You really had to, the patients really had to be the historian of what's happening and the connector across everything in the healthcare system. So that's how I grew up, and that was really my interest in the idea of a person having a complete record about them that they themselves understood, but also that allowed them to explain themselves to the whole medical system. Last year, we wrote this book called Personal Health Records for Governments. It's available open access on phr4gov.org if anyone would like to read it. It's got 16 different countries, including England and Wales. But you can just see this is an obsession of ours. I'm going to start with explaining what we do in England with the Patients Know Best platform as a single patient record, and then I'll cover some other countries just to show what we've learned from working in those environments. So we've got about 22 million people's records in Patients Know Best across the UK. What that means in practice is that there's data coming in from all kinds of sources. So whether it's coming from a hospital customer or a mental health provider, if it's got an NHS number, it ends up in the same single record for that patient. And then what we rolled out last year is that anyone who registers for Patients Know Best with the NHS login, we also pull their full GP medical record, the same that's in the NHS app. We make that available. So it's the same vision behind the single patient record. We completely agree with it, and we're so pleased that NHS England is now focusing on that as the next priority for the government's infrastructure. We also took the same approach that the SPR vision took, which is everything that we have in our SPR, we show directly in the NHS app. So we have 10 screens in the NHS app that are clinical, so beyond the Wayfinder administrative appointment booking screens that Martin O'Neill was talking about. We also have 10 screens that are clinical, so all the hospital test results that are showing up in the NHS app, for example, do so through Patients Know Best screens. We release 22 million test results every month to the patients. We release care plans, you connect Fitbit devices and so on, all of them. It's really important for us and our patients and our customers that everything we've got about the patient, we do show it inside the NHS app. And then because of the NHS app, it's the brand that people trust, they find us in there, and so they register for us at a rate of about 125,000 people every month. We're about to reach 6.5 million people. I wanted to just expand on that GP integration that we did. So we did that for any adult in England, whether they're tied to a customer of Patients Know Best or not. Anyone can register free of charge, either on the NHS app or patientsknowbest.com/register. And when they log in with the NHS login, they authorize us to pull their GP record. About 91% of patients say yes. And then from that authorization, we continue to pull their record for them. And we go beyond what the patient access shows up in the NHS app, in that we store the SNOMED code. So it's not just that you have diabetes and you're taking insulin, it's that we have the SNOMED code for diabetes and the DMND code for insulin. And then we make that available via FHIR API for everybody else that the patient wants or the patient is looking after. So it really is about open standards, open coding, and the data moving wherever the patient needs it to from wherever it currently exists. And then that can also be used in different ways. So you can show the patient additional information because of that's in their medical record. So you can show them clinical trials that the patient matches for, or you can tell them medications that they might want to discuss with their doctor based on NICE guidelines, or as we were hearing from the kidney charity, we can show signposting about an illness from particular charities. Now we do that approach across our platform in every country. So we do the same thing in Wales. We single patient record shows the data in NHS Wales app. They've got slightly different screens, but everything we have, we show inside the app. I want to tell you about some other countries. So in the Netherlands, for example, See My Life built a disease app, which is for blood cancers. And because we've done a national integration, so anyone who registers for us, all the data is available from all providers into Patients Know Best. We then make that available via FHIR API to all of them. And that's basically allows them to build a very disease-specific workflow. Blood cancer is a special case in that the patient has to take chemotherapy for 5 years. If they take it consistently for 5 years, they're cured, they're safe. But often the side effects of the chemotherapy mean that they stop, and they often don't tell their doctor about it. So what the app does is it combines the My Medical data, like the test results from the hospital, and asking the patient on a daily basis which medications they're actually taking honestly and what side effects they're suffering. And then it has algorithms that use the latest guidelines and the personal situation of the patient to tell the patient to dial up and dial down or switch medications to really ensure that patient stays on medications for 5 years. You titrate the adverse events for the maximum benefit of the patient. This is Mid and South Essex, so they're using. They started off from the secondary sector for maternity, and we thought we'd highlight it for the early use cases. They can then the midwives, as they're messaging and writing care plans with their mums at home, they can count on the GP medical record being in there as they message back and forth, and they can collect information from the mum. We include connecting devices like blood pressure or weight from home. There's also medical devices like urinalysis come through. And I think the latest thing they're about to do is release ultrasound scan images into patients their best. And we show all of these data points again inside the NHS app. So it's a single patient record pattern. Wherever the data is coming from, we show it inside the NHS app. And then this is what we recently did for clinical research trials. So this is heartfelt. They're looking for people for their heart failure. They often end up in A&E because they've stopped taking the medication or forgot to take the medication. Often they're elderly, they're isolated, some of them have dementia, and they don't realize, the health system doesn't realize the patient stopped taking medication until the patients end up in the emergency department. And so these guys built an amazing device, which it's a camera that's at the foot of the bed, and just takes a photo of your ankles as you get in and out of bed every day. And they can detect with AI that your ankles are getting a bit wider, then that means that's a sign of heart failure. And then they can call the patient and say, I think you've forgotten to take your pills. Would you like to don't forget to take your pills so it's good for your health. And they needed to recruit patients to measure the accuracy and the efficacy of that. But these patients are quite difficult to get hold of. They're quite difficult to enroll in clinical trials. And so they just used patients in their best. They told the patients about it in the clinical trials based on their health situation. And then within 4 weeks, they recruited 153% faster than any of their previous face-to-face efforts to recruit patients. You basically put the information in the hands of the patient. They click and open up their record and start working directly with the researchers. It really makes the recruitment cycle faster and bigger. This is in Nigeria. So the Nigerian federal government put a law that every state, and Nigeria is 300 million people and the state of Lagos is 20 million people. Every state must have a single patient record platform. Lagos is the first one to go live with their procurement, where every EPR must put a copy of the data in the SPR, and every clinician, before they see a patient, must be able to retrieve all the data from the SPR so they can give safe, efficient care. So it's exactly the same vision as NHS England has had, but because they start with much less infrastructure than England has, they're able to leapfrog in many ways. So they went straight to Fire 4, read-write, and they've got the PKB server. What's interesting in working with them, which is what we found in the Netherlands as well, is how much they struggle with identifiers. So Nigeria has federal identifier, a state identifier, there's private providers, different identifiers, but also they haven't got anywhere near as much usage of the identifiers as we have in England with the NHS. And so they start making, there's a temptation to do shortcuts to avoid getting the right identifiers. And a lot of it is about saying, no, we want to aggregate the information about the same person in one place. Here's all the safeguards you have to avoid bad data about identifiers coming in. In Canada, we just set up a data center there. We're about to go live in a few months. Their emphasis in the beginning was on vaccinations. So we did that work for them, and now it's rolling out in England and Netherlands. And sadly, immunisation has become particularly important in the news, as you know, right now. But part of working in there, we increased our security for SOC 2, which is a North American standard. And then we also learn more about identifiers, because there's a federal identifier, and then every province has identifier. And there are also identifiers for the native population through different healthcare systems. And healthcare budgets are devolved at province level, but obviously Canadians can travel anywhere, and you have to manage all these things it's within that data center. I'm just going to finish back on this one. So that global platform allows aggregating data from all sources. We're just going through an investment right now, which expands the single patient record to store whole genome sequences as well for the patients. So patients who agree to enroll their in research trials will get a free whole genome sequence if they would like it. And we store that sequence, that genotype alongside the phenotype from public sector and private sector, from the home as well as from the hospital, all of that in one environment. So Laura, if I stop there, if there's any questions from people.
Fantastic. Any questions from the audience? And while you're thinking, I've got a question, Mohammed. So thank you so much for a fantastic presentation. Have you been able to track, I guess, patient activation from having access to Patients Know Best? Isn't there a direct correlation between activated patients and prevention and medicines adherence and so on? Have you been able to show that? Yeah, through your solution.
We see that patients are really interested in the data and they take actions based on that. So one small example was the research when I was showing you, they immediately signed up, they immediately opened up and research. Just to give you some data points of how much the patients would line up behind the single patient record vision of NHS England. So we found early on that when we released data to patients, within 2 days, about 3/4 of them look at the letter that came in digitally. Within 2 hours, 50% of them look at it. So the minute you give them data, they look at it. When we rolled out the GP functionality, we looked at the cohorts of people who said yes, about 91% of them say yes. We found that before having their GP record in their PKB account, about 35% of them logged in at least once a month. From the minute they said yes, they logged in 45% every month. So they really want to look at their data. They really want it in one place. They're really engaged with it. And we just keep on seeing that in every pathway. As you release the data to patients, they take up fewer appointments. They can do PIFU where they know how to manage themselves at home. If you're given the care plan that tells them, call us when you're in trouble, these are the trouble markers, whether it's dermatology, prostate cancer, maternity, they're all following that pattern across every department that rolls it out.
Fantastic. Sorry, I've got one more question. At the start, you mentioned that patients can enter Fitbit data and other, I guess, home devices. Yes. I just wondered what the response, if any, had been from clinical colleagues then presented with this data, and whether that was overwhelming or whether they could utilise it, or how it's used in practice.
So there's basically 3 reactions. The first reaction is, that's really cool. Next reaction, that's terrifying. Now I have to look at it. And what happens if I don't look at it correctly? It is a lot of data. And then the next reaction is, okay, surely there has to be systems that analyze the data at scale and figure out for me what to escalate. So one example is what I was showing you around the See My Life, the chronic myeloid leukemia pathways. Big Picture Medicine is doing that same pattern. Basically, you need systems that ingest all the data and then identify for the human beings what needs human attention and what can be safely ignored. You just scale it. It's very pathway specific, but if you've got an underlying single patient record infrastructure where everyone can cancel all the data being there, you then design pathway specific algorithms for aggregation, analysis, escalation.
Excellent, thank you. Well, I can't see any hands or questions in the chat, so a huge thank you again, and we will share the slides after today. So that brings us to our final presenter. So delighted to welcome Rebecca from Essential Parent. And as I said, the 10-year plan set out maternity as an area of priority. And so we're really keen to kind of invite Essential Parents to give a bit of an overview of their work. I think we've got a video we're going to play first, but Rebecca, did you want to introduce yourself first?
I'll just if that's great, if I'll just introduce myself. Thanks, Laura. Really interesting hearing everybody else's talks as well. So yes, basically my name is Rebecca Shiko. I'm the co-founder of Essential Parent. The background of Essential Parent is we're an ex-BBC team of documentary makers who, when we had children ourselves, we we were used to sort of making BBC One programmes, whereas, you know, it might be something about theoretical physics, and we were always told you need to make something that whether somebody is 8 or 80, it's sort of accessible and understandable. So my co-founder Diana was having her baby, and she'd come over from Australia, and her other in-laws were in Canada, so she really didn't have anybody. And it was those sort of practical things, sort of trying to learn and understand things that you hadn't maybe learnt from your own parents or extended family. So what we started with was a visual guide for baby care, and we kind of did it in the way that we would make a BBC One programme. So getting evidence-based information from the right group. So for example, all our infant feeding information comes from UNICEF UK Baby Friendly. And then what we try and do is do lots of nice filming and close-ups to make it sort of very demo-based. And what we've sort of built from those sort of early days is, which the video will go on to show, is an app that kind of supports families from pregnancies all the way through their childhood up to sort of 19 years and beyond to 25 years for parents who have young adults with complex needs. So we're a parent-facing app. You'll see in the video we're translated into over 110 languages, and we basically provide pathways of care along that parenting journey. So I'll let you play the video first, and then I'll sort of go on to how we've sort of pull into the health record. Okay, thanks. So I'll just try and share my screen now, and just if I go across to that now. Are you able to see my screen? No?
Yes, I can, yes.
And if I click on, are you still able to see it? Great.
Yes,
Okay. So that was a kind of a quick whistle stop tour. Laura saved you from having to watch a much longer video that probably went into slightly boring detail of exactly how it works. But basically what we try and do is help support health teams to deliver paperless information following a kind of a care pathway of information. These are the teams that we're working with across the country at the minute, but I'm going to be talking about Manchester. But basically one of the challenges that we were sort of set up to address, and Manchester's a perfect example of this. If you don't know Greater Manchester, it has sort of 10 towns inside it, and there's a lot of sort of overlap of footprints, whether that's the maternal footprint of, like, if you're a parent in Rochdale, you can't give birth in Rochdale, you end up sort of having antenatal care in Rochdale and giving birth in Oldham. Your health visiting team is all Rochdale based, your early years team is. So what we've built is the in this case is the Greater Manchester Family Hub app, which all parents in Greater Manchester can install. And then once they kind of tell us where they are in Greater Manchester, which town they are, which is their preferred family hub, we then deliver localized information. So it will take into account that they're having their baby in Oldham and they're having their health visiting. And so it basically allows a sort of a seamless delivery of information. So you're not moving from midwifery to health visiting to early years to school nursing to immunisation team. The parent has one app. They load their entire family on, so they have their pregnancy and all their children loaded on, and then each time they're getting some information from their team. So you can imagine in the early days with a baby or during the antenatal period, each time you have antenatal appointment, just before that happens, we send a notification. If you've chosen Polish, for instance, to have the app in, your notification will come in Polish, then you'll get access to your packet of information in Polish, including all the videos and all the local leaflets, and everything will be translated into that language. So that was kind of the challenge that we were trying to support, was to produce consistent information for across Greater Manchester. So it's a really sort of joined up approach, so parents don't feel like they're moving from one community team to another. And that's a kind of an important point to make, is that we're very much kind of community based. A lot of the talks I've seen today, it's amazing to see all the sort of secondary care work, but now we've moved into sort of the supporting this maternal care maternity care. We are now for the first time moving into the realms of clinical information and the electronic health record. So I'm just going to take a sip of water. So basically, because the idea is that across Manchester, all families will have the opportunity to install the GM Family Hub app, and that they will be starting with their antenatal information. So they're currently getting, during their life course, the maternity, health visiting, school nursing, immunisation, and all like local family. So it's really ultra local information. We've been approached by the Greater Manchester LMNS to host the Greater Manchester Maternity Personalised Care and Support Plan, which in sort of plain speak is kind of your birth plan. Am I not sharing anymore? Has that just gone off?
No, we can still see that. I can still see the
Oh,
slide
right.
anyway.
No, sorry, Mike. That's okay if you can still see it. Yeah, so we were approached partly because we're being used across Greater Manchester, but also because we have sort of translation sort of technology within the app. And what we're hoping, so I don't know how many of you have had children, but just to give you a quick idea of what a birth plan is, it's kind of sort of a wish list, but it helps parents or expectant families to kind of have an informed choices about what's going to happen to them in antenatal care, during the birth, and in their postnatal care. So in very simple terms, we would be producing a sort of editable and translatable kind of text-based form that a parent inside the app could start to complete and fill in their own language again. So again, if they're doing it in Gujarati, the drop downs and stuff would be in their own language. They would fill in their options, and then this is where the electronic health record is how do we make that shareable? So we have our own we have a different system in Greater Manchester as well, which is called the eCare system, which allows practitioners to share information with people individually, just via text and email. But we're sort of looking into the opportunity of whether we can sort of fire this text-based form into the electronic health record. And for example, in Manchester, they have a system called My MFT, which is based on sort of HIYH from Epic, and that's basically one of the ways that we could maybe make it shareable. We'll also make it printable, and also a lot of the time the midwives are sort of working in side by side with parents, particularly if they all have the app on their phone translated as well. So if a parent's got it, it's just a place for a place for the form to to reside. So we're in the very early stages of this, which, unlike a lot of the other people on here, they're actually building records and they're very integrated and interoperable already. We've already in the past kind of got permission, and we obviously would be using the NHS login, which is how we would sort of authenticate that person in the app if they were firing their birth plan into the health record so that it was shareable. The other things that we're sort of thinking about as well in terms of interoperability, and we've been approached by health teams, is ideas sort of like, if you consider that a lot of the information that we send out, so if we send out information about gestational diabetes to someone specifically, or they get a breastfeeding course or a smoking cessation course, these are all considered interventions. And there's a lot of interest from, obviously from a public health point of view, that if